يا جماعة ما احنا هو بدأ المؤتمر، ما احنا سامعين، ما احنا شايفين، ولا في أحد سامع ولا؟
السلام عليكم ورحمة الله وبركاته. Me, I am Dr. Hanan Hathout from General Directorate of Infection Prevention and Control. Welcome to everybody in the infection control course in ICU. Welcome to all speakers. I hope that the course will add experience to all of you. The course will be in 2 days that cover important topic related to infection control in ICU, including introduction to infection control in ICU, a hint about standard precaution, transmission-based precaution in ICU, design and infrastructure in ICU, important surveillance principle for ICU, and principle of antimicrobial stewardship program. First lecture will be with Dr. Yasser Khedr, infection control consultant in Military Care Hospital, Riyadh, about infection control, introduction to infection control in ICU. Dr. Yasser, we can begin now.
Assalamu alaikum. Thank you, Dr. Hanan and her team, for giving me this opportunity to talk about to introduce the infection control in intensive care unit. Can you hear me? Hello? Yes?
Yes, Dr. Yasser.
Yeah, you can hear me, okay?
Yes, yes.
So I'm going to start with the introduction to infection control in intensive care unit. And again, I would like to thank the organizing committee for giving me this opportunity. As you know, the ICUs is very important part in each hospital, and most of the hospitals, they are having ICU. And really, even any hospital should have ICU. So if any hospital miss the ICU, usually it is not hospital, maybe this is primary health care or whatever. So this is the definition. The hospital should have an ICU, even one. So I'm going to start with the objective. I'm going to talk about background of the infection control in the ICUs, risk factors, infection control program, surveillance devices and care bundles, and I'm going to give a summary. So if we'll talk about ICUs, only 8% are intensive care units beds. However, the prevalence of healthcare-associated infection has been reported to be much greater in critically ill patients than in general hospital population. And maybe all of you knows this or you experience this. So the healthcare-associated infections are much greater among critically ill patients. Hospital, especially intensive care unit, deal with cohort of patients who are most vulnerable to infection as a result of several factors. So the ICU usually hosts most vulnerable patients who's liable to be infected with healthcare-associated infections. Health-associated infections lead to increased morbidity, mortality, cost, and length of stay, prolongs the length of stay. So morbidity, deaths, cost, and length of stay. So, and also HAIs prolong the ICU and hospital stay as general, as I said, and other studies have noted, for example, CLABSI cost from $30,000 to $60,000 excess cost. So this is a huge cost even for example, for one CLABSI. So total, for example, annual cost for 5 major HAIs in US, the SSI, VAB, CLABSI, C. diff colitis, and CAUTI was $9.8 billion. So this is a huge cost. So if we look to the main infection control or healthcare associated infections, we know SSI, surgical site infections, valve, ventilator associated pneumonias, CLABSI, central line associated bloodstream infections, C. diff, colitis, and catheter associated urinary tract. So all this cost, high burden and high cost. The attributed mortality, for example, for bloodstream infections to be 35%, and for VAP 25% to 71%. So this is high mortality for BSI and for VAP. So we have, as I said, prolonged hospital stay, increased morbidity, mortality, and other risks. ICU patients with HAIs also require more ICU resources than do non-infected patients. Infected patients require more therapeutic interventions, such as dialysis, tracheostomy, use of complex invasive devices that require skillful monitoring and manipulation. So when the patient there in ICU, infected with healthcare-associated infections, MDROs, whatever, VAP, CLABSI, CAUTI, he will needs more interventions, more complex invasive devices, needs more skillful monitoring and manipulation. And this is also increase the risk for other infections. So it is like vicious cycle. So for example, HAI prolong the hospital stay of patients inside ICUs, and as long as the patients stay more in the ICUs, he will get more infections. So this is vicious cycle really. So if the patient goes into this, it's very difficult to be out of it. These invasive devices increase the number and duration of the staff patient contacts. Of course, as the patients have more devices, more interventions, he has more contact with staff. So infections can be transmitted from the staff to patients and from patient to staff. Among risk factors, many risk factors, aging populations. So usually ICUs host aging patients, aggressive medical interventions, as we said, central lines, devices, intubations, bolus catheters, whatever, survival of patients with underlying disease or immunocompromised status. So we have immunocompromised patients there, traumatized patients, RTAs, whatever. Transplantation also, sometimes patients with transplantation, complications, immunocompromised with medications, all usually you'll find them in the ICUs. Implanted foreign bodies, sometimes there. And the shift to outpatient treatment leaves the hospital, in particular ICUs, with the cohort of patients that is most vulnerable to infection. So now most of the hospital, if the day surgery or outpatients, those walking patients, they will go there. So you'll find in the ICU the most sick patients there, the most vulnerable patients there. The most patients needs medical interventions, devices, and immunocompromised patients there. Here, one of the risk factors, the staff. Lower nurse to patient ratios are associated with increase in late onset of VAP in ICUs. This is in one of the studies. So if you have a low nurse to patient ratio, this can increase VAP, and actually can also, studies shows that more than 20% of all site ICUs acquire infection could be prevented if the daily nurse to patient ratio, total number of nursing working per day, divided by the patient census for that day, is maintained above 2.2. So this is one in some studies shows that 20% can be really prevented if you increase the patient nurse to patient ratio. And of course, as I said, the hospital stay, ICU stay. So but the patient stay in the ICU, he's more likely to develop healthcare-associated infections. And if he develops healthcare-associated infections, he's going to stay more in the ICU. So ICU patient at high risk for developing infection or colonization due to prolonged lengths of stay, as well as many other factors. Okay, so for example, physician rounds, daily meeting, bed utilization, use of bundles to decrease ICU lengths of stay. This also can work. Okay, so it's very important to try to shorten the patient stay as much as possible in the ICUs. Healthcare
هتعمل دي، شايفي الخضراء هتقف عليها بس لازم تكون فاتح المخدر قبلها.
Vaccination, healthcare worker vaccination of healthcare worker is an important element of patient safety. So this is especially true for COVID-19, for example, and seasonal influenza vaccination. And this has been shown to be the most effective strategy to prevent the spread in healthcare setting. Patients cared for in the ICU setting are high risk and are likely to experience increased morbidity and mortality if infected with influenza or COVID-19. We know this. So they are immunocompromised, they're liable to have more complications if they're infected. So one of the good strategies is to vaccinate the healthcare worker working there. For example, for annual influenza vaccine, or now like the COVID-19 vaccine. Because if you have a patient, a healthcare worker, nurse or physician or physiotherapist or whatever, having symptoms and signs working there with COVID-19, or he can start an outbreak there easily. Among immunocompromised patients, among aging population, among patients with already vulnerable to any infections. So usually there will be like high morbidity and mortality there. So this is very important to be sure that all the healthcare working there are vaccinated. Environmental measure, my colleagues, they are going to talk in details into this, but I'm going here to highlight that environmental measures is very important in the ICUs. Here we're talking about not only adult ICUs, NICUs, burn unit, okay? So all types, surgical ICUs, medical surgical ICUs, neurosurgery, whatever. So here environmental measures like airborne infection isolation room, and that is the negative pressure room, is very important because usually you need the negative pressure room or airborne infection isolation room in critical care units because most of the interventions there are aerosol generating procedures. So for example, for COVID-19 or even for like influenza, which needs droplet and contact usually, but when you do an aerosol generating procedure, you need to upgrade this to an airborne. So usually we need the negative pressure airborne infection isolation room in critical care units, and we need to have them in a good number. So to cover all the possibilities that any patients is going for aerosol generating procedures, and most of the patients actually they're intubated. Most of them or all of them, they will be intubated, and they will be like sometimes we hope it's closed section, not open sectioning system, but you will have another, for example, nebulization, high volume nebulization. You will have sometimes maybe open sectioning or reintubation or extubation or ambu-bagging. All this is considered as aerosol generating procedures, and it should be done in a negative pressure room. Of course, with the airborne precautions, N95 or PAPR for the healthcare workers. We need a positive pressure room sometimes for the severely neutropenic patients, patients severely immunocompromised. We need them for protective isolation. To start the protective isolation, you need some positive pressure room maybe, and those for highly immunocompromised, high neutropenic patients. So you need to protect them, usually if there is any construction or anything going on. And of course, if there is a construction renovation, there should be a good policy there to be implemented that patients in critical care units will not be affected by construction renovation. For example, if you have a adjacent unit with construction renovation, you need to be sure that you isolate, for example, the ventilation system, you have good HEPA filtration, you have negative pressure in the construction if it is major construction there, because you host in the critical care unit immunocompromised patient that can be infected, for example, with aspergillus or any molds. The last one here is cleaning and disinfection. Sorry, this is cleaning and disinfection, not clearing. It's cleaning and disinfection. So cleaning and disinfection is two arms usually here. We're talking about medical equipment cleaning and disinfection and general housekeeping cleaning and disinfection. So like environmental surfaces for medical equipments and other housekeeping surfaces. So this is very important in the ICUs because here most of the multi-drug resistant organism and others can be transmitted through, for example, medical equipments or from environmental surfaces. If the staff, they are not doing good hand hygiene, it will be transmitted from patient to patient or from healthcare worker to patient. Infection control program in the ICU. So this is why we should have a proper, comprehensive infection control program in the ICUs. So when we design the infection control program in the hospital, we have to pay more attention to patients in critical care units. And actually, when we'll do like surveillance, we'll do usually targeted surveillance. We target the ICUs, we target the high-risk patients, we target usually the patient with devices. So this is the core of the infection control program. So the core infection control program usually in critical care units. Because if we will see all, for example, the surveillance is around the CLABSI, CAUTIS, VABs, and like that. So where is the intubated patients? Patients with ventilator usually in the ICUs. Where is the patients with central lines? In the ICUs. Where is the patient, most of them in the Follis catheter? ICUs also. So where is the patients, SSI surgical patients? Sometimes after surgery, they will be transferred to ICUs also. So here we have to target, and the core of our infection control program should be an ICUs, should be patients with devices, high-risk patients. So the ICU infection prevention control must be designed to identify and reduce the patient risk for infection and adverse outcomes. Use of evidence-based guidelines as shown by prospective observational studies can reduce rates of the ICU's infection, especially when tactics are bundled. Here we talk about bundles. So here we have surveillance and we have bundles. Bundles for preventions. So here we should prevent first, and then if something happened, we're going, for example, to discover it by the surveillance. We have to define it, we have to work on it to control it. So prevention is first with bundles. So the elements, this is important elements. This is not the whole thing, but this is part of it. The most important element should be in the infection control program in the ICU. So first, we should have a very strong surveillance system in place. As I said, targeting all the critical care units, all patients with devices, and also we should have a competency-based training and education. So training education linked to the competencies usually. So if you are training for hand hygiene, you should link it to competency. PPE, personal protective equipments, training education, you should link it to competency also. So everything should be competency-based training and education. Prevention care bundle, and this is the most important for CLABSI, CAUTI, VAB, MDR1, SSI. So I think all of you or most of you knows the prevention care bundles, and my colleague will talk about it in details. So those bundles is very important to be in place. Standard precaution, hand hygiene. So the standard precaution is a core of the infection control. Standard precaution is for all patients. So we have to put a standard precaution in place to train, educate, do competency-based training for all elements of standard precaution, including hand hygiene. Hand hygiene is one of the standard precaution, but this is the most important element in standard precaution. Hand hygiene is very, very important and can be linked to any HAI, can be linked to CLABSI, can be linked to CAUTI, VAB, whatever. So, and then we have to think or to implement empirical isolation precautions. Because most of the time, patient admitted to critical care and we don't know till admitted to the unit and not yet, for example, the culture, not yet definitive diagnosis, only symptoms and signs. So we have to implement empirical isolation precautions, put the patient, for example, on contact, empirical isolation precaution, till the result of, for example, MDRO will come. So if the patient is clean, nothing there, you can DC the empirical isolation book. Otherwise, we'll continue contact if the MDRO is there. Transmission-based precaution, this is definitive isolation precaution when you have, for example, multi-drug resistant organism, and my colleagues also will talk in details regarding the types of isolation. Surveillance. As I said, surveillance is the most important element here in the program if you are going to design an infection control in the ICU. So surveillance for HAI is an important element for infection prevention control program in the ICU. Standardized definition must be exact and applied consistently. So we should not change any definitions. For example, if we choose the CDC and HSN definition, we should apply it exactly and apply it consistently, because most of the time we need to benchmark with CDC, for example. So we should not change any definitions. Okay, to benchmark rates with other institutions, the same definition must be used, of course, because if they are using CDC and HSN definition, we are using CDC and HSN, we can benchmark. If they are using any other definitions, WHO or whatever, you cannot benchmark with them. In addition to obtaining numerators through the use of a standard definition of an infection, device days are required for denominator to provide the most meaningful data. We know the rates. You need numerator and denominators. Numerators, numbers of infections, for example, number of CLABSI, county, whatever, numbers of infections. Denominators, usually device days, either central line days, Foley catheter days, ventilator days, whatever. So this is the rate when you are going to do, for example, CLABSI rate, county rate, whatever. So you use the device days, you will not use the patient days. Patient days will use it in something called the device utilization ratio. So this is device days divided by the patient days. This is something different from the CLABSI rate or county or whatever. NHSN data shows HAI surveillance combined with the targeted interventions can reduce HAI rates, morbidity, mortality, and improve patient safety. Of course, here the surveillance, if you combine it to interventions, for example, bundle, so surveillance plus bundle can reduce HAI rates, can reduce morbidity, mortality, and improve patient safety. And this is the most important. So you have to have your effective, consistent surveillance in place. You implement bundles, prevention care bundles, and this can reduce the rates and morbidity and mortality. For example, as I said, if you use the same definitions of surveillance, you can benchmark, for example, with CDC and HSN, for example, pool mean for any ICUs. For example, here they are putting the pool mean for HAIs for critical care. For example, medical, surgical, and even for the type of hospital, like major teaching hospital or a small hospital or whatever. So here, you should use the same definition, NHSN, the CDC definition, then you can benchmark with the NHSN pool mean for a specific ICU. And also, as I said, device utilization ratio, and this is device days divided by the patient days, and this is important. And I think the one who will talk about the surveillance will talk about the importance of utilization ratio. And this is very important because sometimes if you have high rates of HAI, this can be due to increased use of the device itself, or can be due to how they utilize the device. Yeah, for example, it can be, for example, if you have high CLABSI rate in a unit, you can address this because the utilization ratio is high, So those people using more central lines, this is why they are going to have more infections. Or and if the device utilization ratio is normal or less, this means that, for example, they're inserting central line inappropriately, or they are not following aseptic technique. So the problem is not in the how many they are inserting, but the problem is how they are inserting the device, how they are doing it, how they are maintaining, and how they are inserting it. There is something different from NHS and CDC, and that is INIC, International Nosocomial Infection Control Consortium. They have pool mean, and those the INIC, because including many countries outside US and North American. So you have, for example, the developing countries and other countries and developed country also. So you have a huge number of many countries with usually the rates, the pool mean rate higher than the CDC and NHS. For example, here, if you have INIC and NHS, you will find, for example, here, the collapse rate, for example, in the NHS pool mean is 1.8, but in INIC is 6.2. For example, in coronary ICU. In the collapse here, for example, 6.1 county, 3.7, and compared to 2 in the CDC, VAB is also like 10. So you can use INIC or also for benchmark. Invasive devices. As I said, most of the patients, all patients in the ICUs, they're having one or more devices, and usually more than one device, invasive devices. What is those invasive devices? Those central line venous catheters, urinary catheters, intubations and ventilators, nasogastric tubes, gastrostomy tube, external jugular drain or whatever, external ventricular drain. So those invasive devices, why we're afraid from the invasive devices? What is the rationale behind those devices? Those devices, they are passing usually the normal defense mechanism in the body. For example, the central venous catheter bypassing the skin, because usually organism will not get access to the blood because there is a skin and there is subcutaneous tissue and there is whatever. So any organism in our skin will not go directly to the blood. But if you put something like a tunnel or a catheter or anything like central venous line bypassing the skin and subcutaneous tissue and goes to the vein or goes to the artery or whatever, and this is access to the organism. So if there is any contamination from the catheter itself or from the infusions or from the healthcare worker hands or whatever, it's easy for the organism to go inside the blood and cause BSI. And this is true also for endotracheal tube, and this is for the urinary catheters. So it's easy for the organism to travel through the catheters, urinary catheters, central line catheters, or ventilators, or endotracheal tube to go inside the lung, causing pneumonia, causing UTI, and causing BSI. So this is the rationale why we're doing targeted surveillance, why we're doing bundles, why we're doing bundles for those. Here we'll talk, I'll just give a hint or just overall view regarding bundles. So what is prevention care bundles? And those group of interventions, when implemented together, will give better outcome than when implemented individually, and are evidence-based best practices. So when I say that implemented together means all or none law, all or none law. So if you have 5 elements in a bundle, okay, so you should implement it together. You should not miss anyone. If you miss one, means 0. If you implement it all, means 1. It's implemented. So you have to implement it, all of them, to give better outcome. Every one of the bundles is beneficial. Any one of the bundles, elements, individual elements is beneficial, but when you implement it together will give better outcomes. And this is the concept behind the bundle. احنا بنقولها بالعربي كده حزمه. فالحزمه يعني بتكون قويه وما بتنكسر. فthis is the thing behind the bundle. So it's very beneficial and evidence-based. When we say evidence-based, best practice means what? Means even if you have, for example, low rate of any HAI, for example, collapse rate is low in your unit. Do you want to implement bundle or no? Collapse bundle. Do you want to implement collapse bundle? Yes or no? And why? Okay. So the answer here will be yes, because here the bundle is not only to prevent collapse, and this is evidence-based best practice. You don't want to insert a central line with anything done aseptically. You should insert a central line aseptically. You should use the PPEs, whatever, antiseptics. So this is evidence-based. Whatever the situation, whatever your rates, even you have 0 rates, you should implement bundles, care bundles, because this is the best practice you should do. Insertion bundle, because sometimes we observe this in some of the hospitals when we go for example, in Sibah or whatever, that they're telling you we're not doing bundles because our rates 0. We have collapse 0, count is 0, whatever 0. So no need to do bundles. But this is incorrect. You should still do bundles to maintain the 0 or to do, because you should do the best practice. You should not allow the healthcare worker to insert central line anyway. You should not allow them to do inserting false catheter anyway. You should not let them do the, for example, anything without a bundle. Everything should be with a bundle. Okay, so insertion bundle and maintenance bundle for collapse cavity prevention. So we have insertion and we have maintenance, and I think my colleague, they are talking in details about the elements. And also we have VAB, ventilator-associated pneumonia, multi-drug resistant organism, and surgical site infection prevention care bundle. So for example, we have overall rate, sometimes getting compliance rate of a bundle, and then also we can calculate the individual elements compliance. So the overall rate usually follow the rule of all or none law. Okay, so either all elements in place or 0. Even one not met, so the bundles here for that patient, for that moment, 0. Individual element compliance, you can do it. Then to allow yourself or to allow the organization to detect which elements usually is the cause of the low compliance. So as a summary, ICU are targeted areas for infection control program, as I said. So first, to think when you put infection control program, be sure that your comprehensive infection control program cover the ICU properly. Due to high risk factors for acquiring healthcare-associated infections, because we said we have the most vulnerable patients there, we have immunocompromised patients there, we have aging population there, we have traumatized patients there. So for all those reasons, we have to have a proper infection control program. And as I said, fulfilling all the important elements in the infection control program, starting from the very simple hand hygiene, care bundles, surveillance, and other like environmental and other elements. So comprehensive and effective infection control program can prevent many HAIs, and this is true by many studies. So among many interventions, hand hygiene, and I say hand hygiene again, because if the organism in the surfaces, medical equipments or whatever environmental surfaces, it will not get access to the patient unless somebody carry it. All multi-drug resistant organism and other will not fly. When we don't have any organism fly, maybe only TB bacilli or mycobacteria tuberculosis that can fly. So most of the bacteria will stay there. So either environmental surfaces, medical equipments, or bed, whatever. But somebody who is not doing hand hygiene and when going to insert a central line will carry this organism to get access to the blood of patient. So will end by BSI. But the bacteria there and the environmental will not go to the blood. So hand hygiene is the most critical factor for the HAI. So any organism outside the body will not go, even on the skin, our skin. Sometimes the patient will be colonized by organism, but it will not get access to the blood unless also somebody put it there, or he did not clean well or whatever, and insert a device there, peripheral line, central line, or whatever, and or false catheter, and will push this organism inside. So hand hygiene is the most important thing to do. Isolation precaution, as I said, as empirical isolation precaution or transmission-based precaution, or even protective isolation, protective environment isolation, all this is the best to do for isolation. And I said hand hygiene and bundles. Even now, JCI, they introduce care bundles to the to put it with hand hygiene as international patient safety goal. So now international patient safety goal is including hand hygiene and prevention care bundles. So they added the prevention care bundle because it's the most important thing to do to prevent infection after hand hygiene. So here I'm going to, so thank you. And if you have any questions. I hope that I am not fast and you understood. Do you have any questions? I'm here. I try to give an overview. My colleagues, they're going to give more details regarding surveillance, regarding isolation precaution, regarding devices, environmental of care, and whatever. So here, this is just an introduction. So there is a question regarding how make a surveillance. I will not talk in details into this, but maybe my colleague will do this. But I'm telling you the outlines. Surveillance, as I said, is the most important thing to do. First, you have to have, as I said, very important, you should include all the critical care units as part of your targeted surveillance. So included all critical care units there should be in your surveillance. And then after that, you have to have your definitions, CDC definitions, for example, the updated one, train your ICPs, okay, and go for surveillance because, you know, and you should also, for example, find the, as I said, we target devices. You should include CLABSI, CAUTI, VAB, SSI, MDROs. So surveillance is a long story. I think my colleagues, they are going to talk into details. I don't want to go into details of surveillance because this needs a separate lecture. We need all the lectures in our email. I think this is the organizing committee is going to answer regarding this. You can write. If you have any questions, you can write it. Just write it in the chat if you have any question. Regarding, there's a question regarding the routine culture in the ICU. Is it a must? No, it is not a must. This is active surveillance cultures have some rules. There is many details in that, but usually when the patient admitted to ICU, as I said, we'll put him in empirical isolation precaution and we'll do usually active surveillance cultures for some targeted organism, MDROs, and we'll see if the patients, if this patient have this MDRO or not, and then we can continue or DC isolation.
Thank you, Dr. Yasser, for this interesting and beneficial lecture. Now we can go to second lecture about ICU design and infrastructure. Dr. Ahmed Farouk, Director of Infection Prevention and Control Security Force Hospital, Mecca. Welcome, Dr. Ahmed.
Thank you, Dr. Hanan. Thank you very much.
Welcome, Dr. Hanan, and thanks for the organizing committee. Is my voice is clear?
Yes, I think yes.
Okay.
Until Dr. Ahmed present his lecture, please, all of you should finish the pre-test, please, because we will close it soon.
My screen is shared right now and obvious for everyone?
Yes. Yes, Dr. Ahmed.
It's okay. So welcome again, welcome everybody, and thanks for the organization committee for giving me this chance for discussing some interesting topics related to ICU. As you know, the current days, the ICU is one of the hot areas in our hospitals due to the current pandemic and COVID. So I believe this course came in time, and I will try to give, and with my colleagues, inshallah, to try to deliver to you some important information and knowledge about ICU care practice. So let's start. We'll have today a journey in the ICU. We'll start with the ICU design and construction. Where's the location, and what's the content, what's the capacity, what's a negative pressure room, what's the positive pressure, what's the difference between both types of rooms, and when to utilize each one. And finally, inshallah, we will talk about the auxiliary rooms, for example, clean utility, dirty utility, janitor rooms, lounge even. We will discuss about the required specs, and we will finalize with the general outline of the construction inside ICU. If we will conduct a construction activity, for example, we will renovate some room, we will have some painting, open the ceiling even, it's considered as construction. So what's the required IBC practice there in order to prevent infection transmission? So let's start with the design and construction in ICU. As you know, it is very important to implement or to apply the latest infection control requirements in designing and construction before launching the hospital. If you started already the hospital and prepared everything for kickoff of the hospital to start to receive the patient and start giving care to the patient without applying the IBC practices, you will discover at the end that you will lose a lot of money, and you will lose even your reputation in the market if we are talking about private hospital or something like this. As IBC practice is not a fancy issues right now, it's a basic and should be implemented from beginning. If it's not implemented from the beginning, it will be too difficult to be applied later, and we will have a lot of outbreaks and a lot of affection with the patient safety, and even can reach to the staff safety themselves can be affected for improper implementation of the IBC practices. Also, as we discussed before, if we don't have this IBC practice at the beginning of the hospital, we will affecting the environmental disturbances. It will affect everybody in the hospital, as we discussed before. For example, as you know, for dusting accumulation, this dust accumulation can spread aspergillus, airborne aspergillus disease, and also if we are talking about waterborne infection, for example, Legionella species may be spread also if we have a contamination in the water supply. Type. So what's required, or what's main requirement of the ICU in any healthcare facility? As a location, the ICU should be located in the same building as a service and or the department. For example, it near to the emergency, near to the respiratory therapist, near to lab, near to radiology and surgery. And we are talking about critical ill patients. So this service should be very near or very close to them. It's not applicable to have the ICU in separate building and have a distance between this building and the other buildings that have these services. It may cost the patient life in this situation. So during selection of the location, we have to make sure that it is located in the same building as much as we can. And also it should be located to the accessible or easily to be accessible to the medical CPR team. Medical cardiopulmonary resuscitation team, in case that there is a code blue or something like this, a code blue team can access the ICU very easily. He is not in need for going to another building, or not in need for running very high stairs or something like this. It should be convenient in place and accessible to the services, and also accessible to the medical CPR team. Moreover, the location should also not permit unrelated traffic or staff to cross this unit. It's not logic to allow the ICU as an open space and anyone to access another unit after the ICU to cross through the ICU. This is not accepted at all. We are talking about critical patient, vulnerable patient, so we have to select the location very carefully in order to achieve these two criteria in the beginning and not allow any unrequired or unrelated traffic to come through this unit. Also, for space requirement, for a space separate room, if we are talking about two models of the ICU, we have separate room or cubicles for single patient use. This separate room should be at least 150 square feet, or we can talk about 14 square meter. If you are talking about multiple bed space, shall contain at least 100 square feet. This size here decreased from 150 to 130, and here we are talking about 13 square meters per bed. Okay, so again, if we are talking about two models here, we are talking about the separate room model. At least the space is required is 150 square feet, and if we are talking about multiple bed space or cubicles, this can be accepted up to 130 square feet per patient bed. So what about the general requirement of the infrastructure for the ICU or whatever the place inside the hospital? But here we are talking about mainly the ICU. All clinical areas, walls should be painted with a smooth paint. Of course, it should be smooth surface, easy to be cleaned and disinfected with approved disinfectant. Okay, for some hospitals are adding some kind of wallpapers to the walls finish, and this can be rough surface and not easy to be cleaned. This can harbor a lot of microorganism and infection. So here again, we have to emphasize that walls should be painted with a smooth paint, easily to be cleaned and disinfected, and if better to be antibacterial paint. Also for the floors should be covered with smooth materials and easy to be cleaned and disinfected with approved disinfectant, for example, vinyl. Okay, this is very important, especially in the ICU. Ceramic tiles or something like this, it's not accepted inside ICU. So at least in the critical care areas, high risk areas, isolation room, ICU, pediatric ICU, neonatal ICU, burn unit, we should emphasize that the floor should be of vinyl type. Medical vinyl, smooth material and easily to be cleaned and disinfected. Type. For the decorative hidden areas, if you observe here, some of the decorative hidden areas in the ceiling tiles, in the ceiling of the room is not accepted in the ICU. A lot of dust can be harbored here and can be hide here from the daily cleaning disinfection. And as we agreed before, if you remember in the first slide, we're talking about that dust can cause spread of Aspergillus infection. So hidden or decorative hidden areas is not allowed inside the ICU or critical areas in general, as it can harbor a lot of microorganisms and dirt. All posters and signs as a general requirement should be made of or covered of cleanable materials. Plastic can be covered by plastic, laminated by plastic, it's accepted, made of acrylic is accepted. The idea is that it can withhold the cleaning disinfection on daily basis in order to make it cleaned or disinfected easily. Water fountains should be avoided in clinical areas. As you remember, the second slide also discussed today, water can be source of Legionella infection or other microorganisms can spread through water. So water fountains should be avoided in clinical areas in order to avoid stagnant water and splashes that can carry a lot of microorganisms and can spread the infection to the patient. Carpet and the cloth covering of the seats should be avoided in clinical areas as they are very difficult to be cleaned and disinfected. Here again, we are talking about patient may having bed sores, may having something like this. So if the patient will move inside his room, even the chairs inside the patient room should be covered with leather, should be covered with a smooth, easily cleanable surface. Carpets or cloth covering, it's not accepted, as if the contamination or patient secretion can have stains on these carpets and it will be difficult to be cleaned and disinfected. Let's move for the hand washing station, and here we are talking about station, not talking about hand washing sink. Hand washing station means that each hand washing, in order to be a hand washing station, we are need for the hand washing sink and also a poster for the steps of the illustrating the hand washing steps, and we are also in need for the soap dispenser and tissue dispenser. These four elements is what's called the hand washing station. hand washing alone or hand washing sink alone, it is a sink. But if you are talking about the station, which is required by the standard, it should be sink, poster illustrating the steps for the hand hygiene. And also we are talking about soap dispenser and tissue dispenser. Hand washing station shall be conveniently placed to near the nursing station and patient bed areas. It should be present in the nursing station, and also it should be present at each patient bed, each patient room, inside each patient room. There should be at least one hand-free hand washing sink for every 2 to 4 beds in ICU. If we are talking about open space ICU, like what we discussed in the beginning about the space requirement, we have 2 models, either single room, 150 cubic feet, or we are talking about open space, 130 cubic feet per patient bed. In this situation, we can adopt up to each 2 to 4 beds. It's better to have each 2 beds to have a hand washing sink or hand washing station. And if not possible, it can be up to each 4 bed in the open ICU can have only one hand washing station. There should be at least one hands-free hand washing sink per patient room. If you are taking, I want to focus here on that we are talking here about one hands-free, okay, not open faucet by hand or something like this. It should be non-touch. Okay, most guidelines recently discussing that the touching the water faucet, especially in the heavy work or in the daily work, it can transmit the infection again to the healthcare worker hand. So if possible to change all the hand washing faucet to be non-touch or hands-free, it will be the best practice for improving hand hygiene compliance of the staff. Hand washing station should be located near the entrance of the patient cubicle or the room if it's open space as we discussed. And also the hand washing station should be sized to minimize the splashing of water onto the floor. It's very important, and we unfortunately it's observed in some of the old designed hospitals that they are having the adequate ratio of the hand washing station per beds. Every 1 patient room we have hand washing station, and every two patient room we have 1 hand washing station in the corridor. But unfortunately, it is too small. It's too small, so allowing a lot of splashes coming outside, a lot of water dropping on the floor surrounding the sink itself. So this is, again, it's not accepted practice. So during selection of the hand washing sink, we have to make sure, or we have to pay attention to the size. We have to pay attention that some of the procedures inside the ICU may require up to surgical sepsis, for example, insertion of central line or something like this. So you have to select your hand washing sink according to the expected practice inside this location. Hand washing station should be equipped with hands-free operable controls, as we discussed, and also cabinets under hand washing basins are difficult to seal or clean, and therefore they should not be used for storing or any other option. And it's preferably to use wall-hanging hand washing basin. Unfortunately, most of our hospitals are utilizing the under sink space for storing or keeping supplies. In some hospitals, we are checking that they are keeping some of the PPE even under the hand washing station or hand washing sink. This is not accepted. As you know that this is a very high humid area, so a lot of fungus can be present there, a lot of microorganisms can be there, and it's not regularly or daily clean disinfected. So it's not accepted to store anything regardless it's clean or contaminated, anything, it's not accepted there. So according to the guidelines, they are encouraging the designer or healthcare worker during putting the construction or design to the ICU to utilize the wall hanging without any under hand washing sink space for not utilizing as a store. Also, for hand washing basin should be provided with impervious splashback above the hand washing basin rim. If you observe, there is behind the water faucet, it should be the transparent plastic part. It should be present just above the hand washing sink itself and behind the water faucet, in order to avoid the water splashes to catch or to affect the water behind the water faucet, and can produce a lot of microorganisms or fungal growth later, or promote fungal growth. So it's better to add this impervious splashback in order to prevent the splash and protect the wall behind. As we agreed before, hand washing station should have 4 items: sink itself, and we are talking about the poster and soup dispenser and paper towel dispenser. Okay, here we are talking about soup dispenser. We are not allowed using the soup bar. Soup bar is not allowed anymore. Okay, it should be soup dispenser, and it should be non-refillable. The unit one unit or one size unit, it should be replaced after when empty, not to be refilled, or not allowed to empty full one inside the empty one. It's not allowed. So you should have soup dispenser and should be non-refillable type. You should replace the content or the bag itself after being empty with a new one. Paper towel dispenser and waste receptacle should be provided also. Paper towel, it's not allowed to have the paper in the paper box to collect the tissue from the paper box beside the hand washing, or rest it on the sink itself, as it will be contaminated with the splashes and water and something like this. Paper towel dispenser should be hanged beside the soup dispenser in order to select or collect only the required tissue from the paper dispenser, and discard it after drying your hand in the receptacle beside the hand washing sink. So again, hand washing station, we have to have the hand washing sink, we have to have the poster, and also soup dispenser, tissue dispenser, and finally we are talking about the waste receptacle beside the hand washing sink. Mirrors. Some of the common errors that we have: mirrors are installed just above the hand washing sink. It's not accepted, as utilizing mirror or installing mirror in this situation will allow some of the staff to utilize this sink for hair combing, which is not accepted practice. Hand washing, it's very important as a golden rule. Hand washing sink or hand washing station is only for hand washing. Is not allowed anything inside this sink. It's not allowed to wash cup, tea cup or wood or coffee cup inside it. It's not allowed to hair combing or anything. So please, any issue that can affect the practice of hand washing should be eliminated from this station. So the current terminology we are talking about hand washing station, it's not a sink. It's not a regular sink. It's not a sink like other sink in the hospital. If we are talking a hand washing station, certain elements is required, and certain elements should be avoided. Type. Another important issue in the ICU is related to the isolation rooms. Isolation room, it's airborne isolation room, negative pressure isolation room, airborne infection isolation room. It is a terminology that you most familiar with us, AIIR, airborne infection isolation room. Airborne infection isolation room, it is a room designed for the persons that having or suspected. So here we are talking about isolating the patient that is suspected even of having airborne infection transmission. It's not only the confirmed cases, but even we are isolating suspected. I believe my colleagues, inshallah, will discuss in detail the airborne isolation in the coming lectures. Type. So any patient having or suspected of having infection or organism spread by airborne droplet nuclei that less than 5 micron in diameter should be admitted inside this negative pressure isolation room. Here we are talking about tuberculosis, we are talking about varicella zoster as examples, measles into the air, aerosol generating procedure, as Dr. Yasser informed us in the first lecture. Every patient with aerosol generating or airborne infection should be admitted inside this room. No other patient should be admitted here, and this is considered as against the standard. If we found any patient or regular patient admitted inside the negative pressure isolation room, you are exposing your patient to risk of acquiring infection, as this negative pressure room is sucking air from outside, from the corridors, and this patient, if it's not required for this kind of isolation, it can be affected by the microorganisms that can be swept from the corridors to him, especially if this patient is immune compromised. So kindly make sure to utilize only the airborne isolation precaution inside this patient, inside this room, and admit only the patient that is under isolation precaution, under airborne isolation inside this patient room, and no other kind of patient can be admitted there. So this is for the definition of the airborne isolation precaution room. What's the air changes per hour? Air changes per hour, the ACH, this is a common also terminology. ACH or air changes per hour, it measure of how many times the air within a defined space, for example, the room here, is replaced per hour. If we are talking about the air inside the room, okay, we should count that how many this total air can be changed per hour, every 1 hour. We have a calculation related to the amount of air supplied and the amount of air exhausted and the volume of the room. And by engineering equations, we can get to how many this air inside the room can be replaced per hour. This is what's called air changes per hour. So let's another terminology related to the isolation room, HVAC system. HVAC system, it is heating, ventilation, and air conditioning. This is a system that controlling the temperature, humidity of the hospital environment as a general. This is the HVAC system, ventilation and air conditioning system. AHU, air handling unit. And this is very important. We have, as an infection control, to know this terminology as you during reviewing the innovation activity, or if you are reviewing even the parameters of the negative pressure isolation room or something like this, you may find this terminology in the guidelines or the paper submitted to you for review by the engineering affairs. So you should be aware about this terminology. AHU, it is meaning that air handling unit. Air handling unit, it is a device used to condition and circulate air as a part of the heating, ventilation, and air conditioning HVAC system. So the system itself called HVAC system composed of multiple AHUs, air handling units. Each unit is responsible for condition and circulate the air. This unit is like that we are looking in the photo here. Each unit composed of big large metal box. Inside this large metal box, we have a blower, we have a heating or cooling elements according to the purpose of use of each air handling unit. And also we have multiple filter tracks or filter banks here, and we have a sound attenuators and dampers. Okay, this is called AHU. Of course, this AHU, in order to deliver the conditioned air to the patient room, it should pass this air through the ductwork ventilation. From this AHU, usually this AHU are located in the hospital roof, and the air will pass from here after being heated or after being cooled according to the target of this AHU, and will be delivered to the patient room through this ducting system. So what's the requirement of the negative airborne infection isolation negative pressure room? Negative pressure isolation room, ICU, should have at least one airborne infection isolation room for each patient bed. ICU should have at least one airborne infection isolation room for each patient beds. Right. Location of the negative pressure isolation room. Location of the negative pressure isolation room in the ICU, it shall be permitted to be located in the individual patient care units. It's accepted to have this negative pressure isolation room in the ICU. It can be present inside the admission ward. It can be present, or it's accepted to be present as a separate unit, multiple isolation rooms in one location serving the admission floors, or it can be utilized as one or two negative pressure isolation room inside the ICU itself. Okay, so both regimen are accepted, either to be allocated as a whole in one place or present separately inside the hospital units. Negative pressure rooms should be located at the entry of the inpatient unit or the ICU unit, so that the patient requiring isolation doesn't need to pass other patient areas to access the isolation room. In this situation, we are talking about if we have a patient that this patient can be transferred from the ICU, for example, to radiology, or will be admitted to ICU, it's not logic to allow this patient with positive tuberculosis, pulmonary tuberculosis, for example, to cross the whole ICU in order to reach to the negative pressure isolation room. No, it should be located must conveniently at the entrance of the unit in order to just admit the patient directly, not to cross the whole ICU to reach the negative pressure isolation room. So what's the capacity or what's required inside this ICU negative pressure isolation room? Each negative pressure isolation room shall contain only one patient bed. Only one patient bed. And it's not accepted to have two patient bed for cohorting or something like this. No cohorting in airport. Okay, so it's only one single, only one patient bed. It should be present inside the negative pressure isolation room. Provision shall be made for personal protective equipment, PPE storage at the entrance to the room. It should be present at the entrance of the patient room, a drawer, shelves, anything, cart, in order to keep the personal protective equipment. This is in case that we don't have an anteroom. If we have an anteroom, we will discuss later, but if we don't have an anteroom, this drawer or PPE cabinet should be present at entrance of the negative pressure isolation room in order to allow the personal protective, the healthcare worker to wear this PPE before accessing this patient room. Hand washing station, according to the following requirements, it should be again for the, here we are talking about negative pressure isolation room, hand washing station. It should be designed to reduce the risk of splashing to areas where directed patient care is provided. And the sink here we are talking about specific depth and size of this sink. The sink basin shall have a normal size of no less than 100 square inches, around 1 meter, 1 square, about 100, about 920 square centimeters, with a minimum dimension of 9 inches. Almost around 23 centimeters in width or length. This is the dimension of the negative pressure isolation room hand washing station. Hand washing station sink basin shall be made of porcelain or stainless steel, here for the negative pressure, and sink basin shall be installed so they fit tightly against the wall and sealed to prevent water leaks. As we discussed before, we should also install the transparent plastic part behind the water faucet to avoid affecting the wall painting behind this water faucet by the water splashes. Hand washing station sink should be operated without using hands, sensor regulated, hands-free, whatever the mean, operated by knee, operated by anything, but it should be without not touch. Also for the negative pressure isolation room, the patient toilet room shall have serve only one negative isolation pressure room and have a bathtub or shower and open directly to the patient room. This is very important. Negative pressure room, it's in order to be classified as a negative pressure room, patient toilet should be installed inside this patient negative pressure isolation room, and the door should open to directly to inside this patient room. Okay, it's not allowed the patient toilet for the negative pressure isolation room to be located outside, or the door in order to access this patient toilet, the patient should get outside this negative pressure isolation room to access the patient toilet. This is not accepted practice. The toilet should be installed and equipped inside the negative pressure room, and the door should be open inside the negative pressure isolation room. A door from the negative airborne isolation pressure room directly to the corridor is permitted if, as we discussed before, anteroom is, if present, it's preferred. If it's not present, it's accepted. So it's accepted right now that the door of the negative pressure isolation room to open directly to the corridor. Type. If the anteroom, what about the anteroom? Anteroom in the previous guidelines, it was a must and it should be present there. But in the recent guidelines, according to the advancement in the ventilation system, and we discussed, inshallah, later in our presentation today, airlock, what's called the airlock. Airlock, it means that the air or contaminated air from inside the negative pressure isolation room, it's not allowed to get outside to the patient corridor. So this contaminated air will not affect the patient in the corridor. So right now it's accepted that if the anteroom is not available, it's okay. But if you can install the anteroom, it will be preferable. It will be advantage, extra value, added value, okay? But it's not a must like what we are talking in the past. Type. However, an anteroom is provided. If it is provided, it shall have the following requirements. Anteroom shall provide space for person to don personal protective equipment before entering the patient room, as we discussed before. If we don't have the anteroom, cupboard or shelf should be installed at the entrance of the negative pressure room isolation itself. If we have anteroom, this cupboard or shelf can be located inside the anteroom, just outside the negative pressure isolation room. Of course, all doors to the anteroom should be self-closing devices. Once opened and you remove the door, it should be closed automatically behind you. It's not waiting it will not wait to be closed by someone, in order to avoid that the staff during hurrying for giving care to the patient to forget closing this door. So all doors to the negative pressure room and the anteroom should be equipped with self-closing devices. What else for the anteroom? Anteroom shall be equipped with at least the following: hands washing station, not sink, okay, as we discussed before, short storage for unused PPE, and disposal and holding container for used personal protective equipment. All of this should be located inside this anteroom. Anteroom should not be shared between isolation rooms. This is very important, and unfortunately it is a common old practice observed in some old-fashioned hospitals, that one anteroom serving more than 2 or 3 negative pressure isolation rooms. This is not accepted. As you will learn during discussing the ventilation of this area, opening the door of any of this negative pressure isolation room will affect the pressure inside this anteroom. So it may spread the microorganism infection to another 2 patient rooms. So very important to pay attention that the anteroom should serve only 1 negative pressure isolation room, not to be shared with any other isolation room. Keep the patient room negative pressure without anteroom is better than sharing this 1 anteroom with more than negative pressure isolation room. So what about the architecture design or architecture details and furnishing of this negative pressure isolation room? For architecture details, negative pressure isolation room walls, ceiling, and the floor, including penetration, shall be constructed to prevent air exfiltration. What's meaning by air exfiltration? As you know that this negative pressure room, we are dealing with this negative pressure isolation room as a capsule. No air is allowed to get inside this room except through the air supply ventilation system, and no air is allowed to escape from this room except through the exhalation opening of the exhaust opening of the HVAC system. So if there is any penetration, any holes, any fissures inside the walls or the ceiling of this room, it can allow the air to escape from this patient room to outside, as this can carry a lot of microorganisms to outside to the corridors and to affect other patient or other healthcare worker in the facility. So any minute, any small holes, any small penetration should be closed permanently and sealed by the engineering affairs in order to avoid any escape of the contaminated air to outside this patient room. So what about doors? Doors of the negative pressure isolation room again should be self-closing device, and also edge seal shall be provided along the sides and top of the door frame for any door into the negative pressure isolation room. What's meaning by edge seals, like what we are detecting here in the picture? This is the rubber seal. It can be installed in the bottom, which is very common to be installed in the bottom of the door, but can be installed around the 4 directions of each door. So this rubber seal, it's very important to cover the negative pressure isolation room in order again to maintain the contaminated air inside the room, not to allow air to get outside by any means. Okay, in order for giving the maximum protection for our patients and for our staff. Window treatment and privacy curtain. A window of the negative pressure isolation room. The window should be completely sealed again and could not be opened. This is very important. Unfortunately, in some hospitals, we can observe that some of the negative pressure isolation room having window and the patient can open this window. It should be sealed and not be allowed to be opened under any condition. It's not allowed to be opened. If it's allowed, it will disturb the ventilation system inside this negative pressure isolation room, and the air coming from outside can push the contaminated air inside the negative pressure isolation room to get to outside to the corridors and to another patient in the hospital, and can transmit infection to other areas of the hospital. So this is very important. Window should be completely sealed and could not be opened under any condition. Window material also should be easy cleaned and disinfected, and the privacy curtain should be washable. privacy curtain should be washable. Some of the curtains are not washable and they should be replaced every time. It's okay, it's okay, but should be it should be either to be washable or it should be disposable, and it should be replaced after each patient after discharge. Floors and wall base assemblies. The floor of the negative pressure isolation room shall be monolithic, as we agreed. What's the meaning of monolithic? Monolithic, it means that it's single layer, single sheet. Okay. So the floor it should be monolithic, vinyl. It should be one layer of vinyl, no cracks, no connection between the vinyls itself, and also it should have the, like the photo here, integral curved wheel base. Integral curved wheel base. What's meaning by integral curved wheel base? Like what we are seeing in the picture here, it should be have this curve in order to make sure that during cleaning disinfection, everything, every inch, every centimeter inside this patient room is cleaned and disinfected, and nothing can be hide. If it is this one, it is sharp edge, it can hide a lot of microorganisms, but it's curved edge like this, it can make it easy for being cleaned and disinfected, and also the lower part of the wall can be saved from affection by the floor environmental or surface disinfectant used in the floor. The distance here should be at least 150 millimeter, about 15 centimeter should be the height here, and it should be present on the room design in order to be implemented during installing this vinyl. Also for the wall finish, again, it should be smooth, scrapable, water resistant, and withstanding cleaning and disinfection by chemicals, and it should be antibacterial, of course. Also for wall finish shall be free of fissures, as we discussed. Any small penetration or any small hole can affect the pressure and can allow air to escape to outside to affect the adjacent patient rooms. For ceiling, again, it's monolithic construction, so it's here we should highlight that present of ceiling tiles, it's not accepted. It should be replaced with the gypsum board, one layer of gypsum board without any opening, at least one opening. It should be kept for only examination above ceiling, but it should be sealed by antibacterial silicone around the edges of this ceiling. And if we have tiles, these tiles should be replaced with this monolithic surface or one layer gypsum board. As present of cracks or perforation, as we discussed, it can affect the pressure inside the negative pressure isolation room. So let's move to the ventilation. All air from the negative pressure isolation room shall be exhausted directly to outdoors. It should not be allowed to circulate the air or to filter the air and bypass it again to other patient rooms or something like this. It should have withstand or separate or standalone system for ventilation inside this negative pressure isolation room. So all air exhausted from the negative pressure isolation room shall be exhausted directly to the outdoor. All exhaust of air from the negative pressure isolation room associated with anteroom and associated with the toilet of the patient room shall be discharged directly to the outdoor without mixing with exhaust air, as we discussed. So it's very important to make sure that the toilet of the negative pressure isolation room is not connected with the toilet ventilation system of the other toilets of the patient room, the other hospital areas. It should be connected to the negative pressure isolation room system, ventilation system, okay, in order to be separated from the other patient areas, okay? And also the anteroom itself, it should be connected with the negative pressure isolation room ventilation system and be separated from the other hospital ventilation system. Right. Exhaust air grills in the patient room shall be located directly above the patient bed, on the ceiling or on the wall near the head of the bed. What's the meaning of this? The exhaust of the ventilation system, the exhaust of the HVAC system itself, it should be located just above the patient head. It can be accepted in the wall, or it can be accepted in the ceiling. Both of them are accepted, but it should be located just beside the patient head. The room envelope shall be sealed, as we agreed before. It is an envelope or capsule, and the pressure inside this room should not be allowed less than -2.5 Pascal. This is very important to hear less, not less than -2.5. So if we found it -2.4, it's good or bad. It's if we found it -2, it is good or bad. It's bad. It's not accepted. Okay, it's not accepted. -2.5, it is the accepted number. If we found it -3, -4, -5, it's accepted. But if we found it -2, it's not accepted. So the at least accepted number -2.5. Type. For immune compromised patient, if we have an immune compromised patient, and unfortunately this patient should be admitted inside this negative pressure isolation room, as this patient, he is immune compromised and having, for example, open pulmonary tuberculosis. HEPA filtration system should be provided on the supply again with the exhaust. Okay, so in this situation, we have an immune compromised patient, and this immune compromised patient admitted to the negative pressure isolation room. So the air supply of this negative pressure isolation room should be supply, not the exhaust. Supply should be supplied with HEPA filter, HEPA filtration, in order to filter the air to provide this patient the ultra filtered or clean air for patient safety. Exhaust air should be HEPA filtered also for the negative pressure isolation room, and should be connected to the emergency power supply to maintain air pressurizing in the event of power failure. What's meaning of this one? It means that as you know that exhaust should be connected to fan in order to suck or collect the air from the patient to outside. So there is a fan. This fan, if not connected to emergency power supply, for example, if there is emergency or electricity power cut off, this fan, if stopped, it means that this room will be transferred suddenly to positive pressure, and the contaminated air inside this patient room can spread to the hospital corridor and affect the adjacent patient room. So in this situation, HEPA filter, it should be installed in the exhaust fan of the negative pressure isolation room, and this fan should be connected with emergency power supply. When an anti-room is provided, the pressure relationship shall be as follows. So right now we have a negative pressure room, and we have an anti-room, and we have a bathroom. So what's the pressure gradient should be there? Which one should be the most negative part in these three areas? Patient room, anti-room, patient toilet. The negative pressure shall be negative pressure with respect to the anti-room. The negative pressure itself, the isolation room itself, shall be negative in respect to the anti-room, and the anti-room shall be at a negative pressure with respect to the corridor. So the pressure gradient means that the corridor will be the highest pressure. It should be positive, or it should be regular pressure. It's not our deal here, but regular pressure in the corridor. In the anti-room, it should be negative pressure to the corridor, and the negative pressure isolation room, it should be more negative to the anti-room. Okay, so it means it is more negative to the corridor, and the patient toilet, it should be the most negative pressure to the patient room. Okay, the bathroom shall be the most negative pressure area at the complex. Again, the corridor, regular pressure required. Nothing here is required in addition. The corridor, irregular pressure. Anti-room should be negative to the corridor, and the patient isolation room itself should be negative to the anti-room, and the patient toilet should be negative to the patient isolation room. In this situation, the toilet is the most negative pressure isolation room in this complex: patient room and anti-room and the toilet. Each negative pressure isolation room shall have permanently installed device and or mechanism to constantly monitor the difference between air pressure and between the room and the corridor. And here we have to emphasize that it's permanently installed. It's not accepted that a portable device, I will measure it right now, and I will leave the room, and I will ask the engineering again to come to measure this negative pressure isolation room. This is not accepted. The pressure alarm should be permanently installed and should continuous monitor the pressure differential inside this patient room. Visual and audio alarm or audio visual alarm should audio visual alarm should be indicates if the negative pressure is not maintained inside the patient room, and shall provide it to each negative pressure isolation room. Also for the pressure alarm, it should give the pressure readings in Pascal. It's the best, or if it's old-fashioned and can measure in water, it's accepted, but it's the best practice to measure it in Pascal and provide continuous reading. As we discussed, it's not switched on, switched off. It's once it should be permanently installed, continuous reading. Any difference in the pressure, it should be give audio-visual alarm immediately. And if possible, to be connected to the building management system, BMS, in order to give an alarm and the engineering control system in case that there is any disturbance in the pressure differential. And very important to be protected from tampering from third parties. It should be inside closed or secured plastic or glass box in order to avoid for being tampered or anyone to change the values or measure of this measuring or pressure alarm monitoring system. So this is for the negative pressure isolation room. Again, as assembly, negative pressure isolation room. If you are looking with me for this picture here, the pressure it's reverse of this one. This photo is only for the positive pressure. Negative pressure is the reverse. So the negative pressure, the air is coming inside, okay, inside to the patient room, coming from the corridor to the anteroom to inside the patient room. But if the positive pressure room, like what we are seeing here in this photo, like we are seeing in the blue arrows, in the positive pressure room, in this photo, the air is coming from inside this patient room to the anteroom to the corridor, okay? Vice versa of the negative pressure isolation room. So the positive pressure, the air is coming from this room to the corridor. Negative pressure, air is coming from the corridor to the negative pressure isolation room. Okay, in order to just clarify the difference between positive and negative pressure. So what about the positive pressure isolation room? Positive pressure isolation room, it is used for isolation of the immune compromised patient, mainly the protective environment. For example, if we have burn care unit, if we have immune bone marrow transplantation unit. So in this situation, we can implement the protective environment or utilizing the positive pressure isolation room. The intent is to reduce the risk of airborne transmission of infection to a susceptible patient. In the negative pressure, we are in fear for transferring the infection from the patient to the healthcare worker or to the other patient. But for the positive pressure, we are in fear to transfer the infection not from the patient, but here to the patient. We are in fear to transfer the infection to the patient. We have a vulnerable or suspected susceptible patient in this situation, so we have to make the maximum precaution for protecting the patient. Again, it's positive pressure, it's only for the protective environment rooms, PE rooms for the immune compromised patient. Anteroom, again, is not required, and if present, it will be favorable. If not present, it's accepted. Positive pressure isolation room requirement, higher pressure in the relation to the adjacent rooms or space, plus 2.5 Pascal. So again, here we are talking about the accepted range. Accepted range here plus 2.5. So it is a stable number or fixed number at 2.5. I just want you to memorize this number. It's 2.5. It's negative 2.5. If it's minus 2.5, it is the least for the negative pressure isolation room. If it is positive or plus 2.5, it means that it is a positive pressure isolation room. So if we have here the pressure more than 2.5, 3, 4, 5, it is accepted, okay? But if it is 2 or 2.1 or 2.4 even, it's not accepted reading for the positive pressure room. Clinical hand washing basin with hands-free operation in the isolation room, it's required. Also, bathroom with shower and toilet, it's required inside this positive pressure room. And self-closing door, it's required. Positive pressure isolation room may share a common air system. Okay, here for the negative isolation room, it's not allowed to share, but for the positive pressure isolation room, it allowed to share for multiple patient rooms, as each patient room equipped supply with a HEPA filter, and we equipped with a HEPA filter on the supply and the exhaust, so the patient is maximally protection. But for the negative pressure isolation room, it is not required, it's not accepted to share the ventilation system. It's only one room. Each ventilation system serves only one room to avoid cross infection. HEPA filter, however, must be fitted to the supply air as we discussed. HEPA filter is not required to the exhaust air, as the exhaust air is not considered infectious in the positive pressure here anymore. But for the negative pressure, we are installing HEPA filter on the exhaust. It is a standard, okay? It is a standard for any negative pressure isolation room to install HEPA filter on the exhaust, not required on the supply. Supply for the negative pressure only for the immune compromised patient if it will be admitted there. But as a standard, HEPA filter for the exhaust of the negative pressure isolation room. For the positive pressure isolation room, we need the HEPA filter standard for the supply, for the positive, for the supply, for all. For the exhaust, it's not required for the positive air pressure. Okay? طيب. HEPA filter is not required to the exhaust air as we discussed. What differential air pressure should be again to be continuously monitored and should be highlighted and permanently installed. Here this is a table in order. I believe some of you may be confused, especially the people that hearing this topic for the first time may be confused with some of the expressions and some of the HEPA filter present supply or exhaust or something like this. This table you will find the full details where the HEPA filter is required, where it's not required, and what's the requirement for a negative standard pressure isolation room, negative pressure isolation room, and positive pressure isolation room. Type. So we discussed till now the handle station. We move to the isolation, negative pressure and positive pressure. Another important areas in the isolation in the ICU should be paid attention for: medication preparation area and room. Intensive care unit must have a separated clean area maintained for preparation of medications. Medication room in order to prepare the medication. Some of the hospital having central IV pharmacy, which is the best practice to prepare the medication in the IV pharmacy and they bring it prepared to you. But in some situations, you may need to prepare some medications inside the ICU and emergency. So it's preferred to adopt a medication area or medication preparation room. It should be a room separated clean area. Medication preparation area must be away from the patient treatment area, and also we should maintain a good ventilation system in order to maintain proper temperature and humidity. This is a medication preparation room. Another area inside the ICU, medication store or medical supply store. Medical supply store ICU must have a separated medical storage area with adequate capacity, and this medical storage area have controlled ventilation system. The temperature should be ranging from 22 to 24, and the relative humidity should be maintained up to 70%. Storage shelves are at least 40 centimeters from the ceiling, 20 centimeters from the floor, and 5 centimeters from the wall. This is the optimum storage condition. Okay, again, the medical store, it should be present. Temperature should be maintained 22 to 24, okay, and the humidity should up to 70%. If more than 70%, it is not accepted. Storage shelf or storage condition or dimension, it should be 40 centimeters from ceiling, 20 centimeters from the floor, and 5 centimeters from the wall. Storage shelves are made of easy cleanable material in order to make sure that there is a frequent cleaning disinfection, in order to avoid dust accumulation. Sterile and clean items are completely separated from the personal items. Personal items is not allowed to be stored inside the medical supply store. Okay, personal belongings, clothes, handbag or something like this, it's not accepted to be stored inside this medical supply store. No items are allowed to be kept in the original shipping boxes, as these original shipping boxes exposed during the journey of transfer from the factory to the hospital storage area to a lot of conditions. It can affect the carton box itself. It can harbor a lot of microorganisms or can harbor even a lot of parasites. So it's important to transfer the goods or transfer the supplies from these original shipping carton boxes to the shelves immediately. Toilet room. For the regular patient room, regular ICU patient room, each critical care area patient room, both adult and pediatric, shall have direct access to an enclosed toilet room. Sink in the toilet room may be provided, but it is not to be used as a primary sink for the hand hygiene during patient care. It's very important. Sink in the toilet room is not allowed to be utilized as a sink for hand washing or hand hygiene. Okay, it not be the main sink. It can be طبعا of course utilized for washing your hand after toilet or something like this, but it's not the main station for the hand hygiene. Dirty utility room. Dirty utility room, it should be separate from and have no direct connection with either clean workrooms or clean utility room or clean supply room. It should be separated from this clean supply room. And soiled workroom used for cleaning, disposal, or reuse of soiled items, like emptying and rinsing bins, emptying or solidifying suction canister, rinsing and gross cleaning of medical instruments. So this dirty utility room can be utilized for keeping everything contaminated inside this room. It can be utilized for storing the contaminated linen, contaminated medical devices to be sent to the CSSD suction canister or something like this. Can be stored for, can be utilized for storage of the medical waste till being collected by the company, or can be also utilized for storing of the surgical instrument utilized before sending to the CSSD. طيب, environmental service room or janitor room, it also important room should be available inside the ICU. It should be available to accommodate carts. As the carts utilized in the ICU, it should be kept inside the ICU, not to be allowed to clean the ICU and the corridors and something like this. It should be kept inside the ICU. The storage or bin space should be included for recyclable materials, white paper, mixed paper, cans or bottles or something like this, but not medical waste. Medical waste in the dirty utility room. One environmental service room shall be permitted to serve more than one patient care unit. Environmental service room shall be readily accessible to the unit or floor itself. So it should be present at least one inside the ICU unit. What's content of the environmental service room? It should be service sink or floor mounted mop sink, provision for storage of supplies, and hand washing station. Last part of the last room that we will visit inside the ICU, it will be staff lounge facility. Staff lounge facility, of course, it should be available, dedicated space for the staff in order to have their meals, or located in or adjacent to the critical care unit. And one lounge should be permitted to serve adjacent critical care areas. And this lounge shall have a telephone or intercom and the emergency call station connection to the critical care unit. So right now, we reached to the end of our journey in the ICU design and construction. And we agreed that design and construction, according to the IBC requirement from the beginning, will save a lot of money and will save a lot of reputation and will save the patient and staff safety. And we discussed together the specs required, negative pressure, what's required by as a design construction requirement, infrastructure for negative pressure, what's required for the positive pressure, which kind of patient will be admitted there. And also we discussed the auxiliary rooms for the ICU, negative, dirty utility, clean utility, janitor room, and staff lounge. This all the furniture or all the locations required for the ICU in order to have safe service inside the ICU. I want to thank you, and I'm ready for question if you have any questions here. Any question? Okay, I hope that if you have any question, we are having a second lecture, inshallah, today. And if you have any question, we can discuss it in the second lecture, inshallah. Thank you.
Thank you, Dr. Ahmed, for this interesting topic and comprehensive lecture that give us detailed information about infection control requirement in ICU design and infrastructure. Thank you so much, Dr. Ahmed.
Thank you, Doctor.
Now we can take a break for 15 minutes, and then we can restart, inshallah. السلام عليكم. Let us start again. Now the lecture will be standard precaution. دكتورة هناء الجهني, GCI Infection Control Diploma, CIC Certified. Welcome دكتورة هناء.
السلام عليكم ورحمة الله وبركاته. مساء الخير. الصوت واضح دكتورة؟ والسكرين برضو واضحة؟
دكتورة هناء.
السكرين واضحة دكتورة؟ السلام عليكم. طيب ممتاز. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه.
دكتورة هناء اتفضلي حضرتك.
دكتورة واضح الصوت؟
واضح دكتورة اتفضلي. واضح.
طيب ممتاز. يلا توكلنا على الله. اليوم إن شاء الله بإذن الله محاضراتنا حتكون عن الستاندرد بريكوشنز. أنا زميلتكم دكتورة هناء الجهني, Consultant Family Physicians, GIC Infection Control Diploma و CIC CBHQ Certified. إن شاء الله بإذن الله اليوم حتكون رحلتنا جدا ممتعة و you will give the maximum benefit إن شاء الله. First of all, I would like to thank the organizing committee for giving me this opportunity to share with this training course. Special thank to دكتورة حنان حتحوت يعطيها العافية. I will start with the simple rules and regulations to get the maximum benefit of this training course or any online courses. You should set up your space and make sure it's quiet and uninterrupted. Be punctual, log in on the time. Please all mute your mic. Don't be afraid to speak up. You can ask any questions at any time, but please introduce yourself first. Our journey on standard precautions today will start with the definitions, when and why we should apply the standard precautions. Then we will talk about the 8 components of the standard precautions. At the end, we will wrap up and summarize all the informations we got in this lecture. First of all, we will define standard precautions. Standard precautions, it's a guideline that outline the minimum set of interventions that are required for preventing transmissions of microorganisms. When we can apply it, we can apply it everywhere in the hospital. So it's the first and basic step in breaking the cycle and preventing the transmissions of microorganisms in all the hospital, and especially in high-risk area like ICU in that area. So it's a basic and it should be applied and intended to be utilized for the care of all patients. So it's a standard to be implemented through the whole hospital and especially in the high-risk area in all healthcare setting. And it can be applied in acute care hospital like ICU, long-term care facilities, ambulatory care centers, and even in home healthcare, even in the absence of suspected or confirmed infectious process or disease. We apply the standard precautions to prevent the spread of microorganisms between different hosts, from person to persons, from our healthcare worker to our patients, or from ourselves to the surrounding environment. Standard precautions is used to break the chain of infections. As we know, all of us are infection control practitioners. We know the chain of infections, and all the infection control measures are tackling to break the chain of infections: the reservoir, the portal of exit, mode of transmissions, portal of entry, susceptible host and disease, or the microorganisms or the agent. So the standard precautions are applied to break the chain of infections. Why we should apply the standard precautions? To protect ourselves as a healthcare worker, to protect our colleagues working in the same facility, to protect our patients, visitors, and environment. Now we will talk about the standard precautions component. We have 8 components. First and the most important component is the hand hygiene, then the PPE or personal protective equipment, handling, disposal of contaminated items, environmental cleaning is another component. How we will place the patients in our hospital or in ICU. What about the food and drinks at workstation? Of course, cough etiquette or respiratory etiquette. At the end, we should use the surgical mask during certain procedures. And now we will start to elaborate on each component separately. We will start with the first and the most important component, which is the hand hygiene. Which hands do you think your hands is? The right or the left? If it is the right, just please write in the chat area 1. If it is 2, write number 2. As I mentioned before, this is an interactive lectures, so it's 2 ways. 1, both. 1, both. We hope it's 1, but actually it's not. Our hands, with the naked eye, it appear clean, but it's not with under the microscope. We have a lot of germs in our hands, and especially when we are working in the high-risk area with many invasive procedures. We have different types of normal flora on our hands. There are 2 types, either resident flora or the other type is the transient flora. The resident flora, which consists of microorganisms residing under superficial cells of stratum corneum, and the transient flora, which colonize the superficial layer of the skin and is more amenable to removal by routine hand hygiene. So we cannot remove the resident type of flora. Of course, we have our good barrier, good immune system, which is the skin. So any break in the skin integrity, it can minimize our immunity and it can induce the organisms. Do you know that handsome guy? Anyone recognize who this man in this lectures? No one can answer these questions. Who is that man in this lectures? This is the father of the, yes, this, you are right. This is the father of the hand hygiene. He is Simi Lewis, and he's a doctor working in the Vienna General Hospital, and he is the first one discovered the relation between the infection and the hand hygiene. He was working in that hospital, and he noticed that women giving birth in the medical ward, maternity ward during in the hospitals were much more likely to develop fever and sometimes die compared to the woman giving birth in adjacent midwife ward. And he decided to investigate. And at that time, he found good relationship between the infection and the hand hygiene in 1850. So, is the relation between hand hygiene and the health-acquired infection rate, is there any relations? Of course, when we are improving the hand hygiene compliance rate, we have dramatically decreased the health-acquired infection rate. And this is different studies supporting this idea. When we are improving the hand hygiene, we are dramatically decrease the health-acquired infections. And this is our main goal at the end of our work. Hand hygiene is a major component of standard precautions and one of the most effective methods to prevent the transmission of pathogens associated with health care. We have 3 terms can be applied to hand hygiene. First, hand washing. Second, antiseptic hand rub. And the third one is surgical hand hygiene. We will elaborate more in those different 3 types of hand hygiene. Hand washing is using the plain, sometimes non-antimicrobial or antimicrobial soap and water. When we are using the alcohol-based hand rub, It's a type of solutions that contains between 60 and 95% of alcohol and designed to be applied to our hand to reduce the number of viable microorganisms on the hands, or in the other terms, the resident flora. The surgical hand antisepsis is hand wash with antiseptic hand rub performed pre-op by surgical personnel, or sometimes we can use it in the ICU to eliminate transient and reduce resident hand flora. And the used antiseptic hand wash preparation should be persistent antimicrobial activity. That means it has long activity to kill the antimicrobial. Other example of antiseptic or antimicrobial agents, we can use the most famous one is alcohol, chlorhexidine, chlorine, iodine can be used as antiseptic or antimicrobial agents. Now we will go to the 5 moments of hand hygiene. I think all of you know and aware about the 5 moments of hand hygiene. Before touching the patient, before clean aseptic procedures, after body fluid exposure risk, after touching the patients, and after touching patient surroundings. This is the technique of how we can wash our hands. And the durations of hand washing is around 40 to 60 seconds with all these 6 steps. And this is how we can use the alcohol or hand rub to clean our hands. And the same technique, but the duration is different. The duration is between 20 to 30 seconds. When we are talking about the hand washing versus the alcohol-based hand rub, which one is the most effective? Is it hand washing or hand rub? If it is hand washing, just please write 1 in the chat area. And if it is the hand rub, just write 2. Some of the answer 1 and the others are 2, based on the situations. But in general, we are talking about in general, which is better, the hand washing or alcohol-based hand rub? There is different opinion. So now we will go to the answers. Numerous published studies that demonstrate alcohol-based hand rub remove bacteria from hands more effectively than hand washing with a plain soap and water. In most studies, alcohol-based hand rub remove bacteria from the hands to greater degree than hand washing with antimicrobial soap and water. So alcohol-based hand rub are more effective in killing bacteria than soap and water. So alcohol-based rub is superior to be used than hand washing. Regular soap, good. Antimicrobial soap is better, but the best practice to use alcohol-based hand rub. So alcohol-based hand rub is more convenient for the staff. Most of the health care worker, they can use it, they can have it easily than the hand washing sink. It's faster, the duration is about the half of the durations of the hand washing. And they found less skin irritations with alcohol other than that skin irritations with the hand washing. So alcohol-based hand rub is the superior to be used than the hand washing. So it's more effective, more convenient, faster, less skin irritations with alcohol-based hand rub other than washing. As I said, again, I will repeat it, alcohol-based hand rub is superior and more effective to be used other than hand washing. Excellent, easy to use. But there is some absolute indications for hand washing. Hand rub or alcohol-based hand rub cannot replace the hand washing in specific situations. Do you know what is it? What is the specific indications for or absolute indications for hand washing? Excellent. Clostridium is one of them. Visibly hand soiled. Excellent. C. diff. Blood. Numerous after body fluid exposures. Excellent answers. Absolute indications for hand washing when our hand is visibly dirty with body fluids. Other indications is when we are dealing with the C. diff patients, because the spores of the C. diff cannot be killed with alcohol. So at that time, we should use the hand washing, not the hand rub. The fourth indications of absolute indications of hand washing during an outbreak. In the COVID-19 outbreak, most of the recommendations, they recommend hand washing other than the use of alcohol. The fourth indications, after frequent use of alcohols, we will find our hands dirty. At that time, we cannot do more alcohol rub. We should go and clean our hands with soap and water. Then we can use the alcohol again. The hand care and hand hygiene. This hand is very pretty and beautiful, but the nail polish and the artificial nail and the rings are not the suitable things to be worn by healthcare worker. Now we'll talk about the hand hygiene and gloves. So did the gloves replace the use of hand washing or hand hygiene? Can we replace the gloves? No, of course. We should wash our hand or clean our hands before using the gloves. We finished from the first component of standard precaution, which was the hand hygiene. Now we'll talk about the PPE or personal protective equipment. PPE, it's a type of special covering designed to protect us as a healthcare worker from exposure to contact with infectious agent. PPE act as a barrier to prevent microorganisms from spreading from healthcare personnel to patients, body, substances or surfaces, or vice versa, from ourselves to our patient. We should use appropriate PPE, gloves, gown, plastic apron, eye protections to prevent skin and mucous membrane exposure. We should use one or more of these items based on the degree and the risk of exposure. And most routine patient care activities at bedside don't require the use of PPE. How we can select the proper PPE while we are doing any procedures? We should ask ourselves 3 questions. First questions, what is the task being performed? What procedures I'm going to do for my patient so I can prepare the PPE based on it, my size as a healthcare personnel, and the transmission-based precautions my patients or the patient was on. This is the most 3 important questions before preparing the PPE. We have different types of PPE: gown, mask, goggles or face shield, and gowns or gloves. Now we'll talk about gown. We should wear the gown to protect skin and prevent soiling of clothing during activities that are likely to generate splashes or spray of blood and body fluid secretions or any excretions. It should be fluid-resistant gown, and we should remove soiled gown as soon as possible and perform hand hygiene. We have 2 different types of gowns, either sterile or non-sterile gown. We should select our gown based on the procedures. And we should select the proper size. We have different small, medium, large sizes of gown. And we should securely fasten the tape or tie to keep the gown plastic apron in place while performing patient care activities in the patient room or in the procedures area. After that, we should remove the gown by untrying the tabs and tie it and remove it away from our body inside outside manner, like the one in the pictures. And we should roll it into the bowl and discard it immediately. We should change the gown after each patient or each procedures. Aprons are not to be worn after leaving the patient room or the procedures room. We should remove it immediately after use it. Now we'll talk about the mask. We have two different types of mask. The surgical mask or N95 mask. The healthcare worker exposed to potentially infectious respiratory secretions should wear the mask. Surgical mask or N95 mask are meant to be used as a single use every after patient's encounter. Surgical masks are not to be worn after leaving the patient's room or in procedures area. We should wear the surgical mask with the protective eyewear if splash or aerosol generating procedures or body fluid is expected. Change mask between patient and sooner if mask become wet or moist or torn. And nowadays, with the COVID-19 pandemic, wearing surgical mask is mandatory in the hospital and even in the community. N95 mask. We should wear it only when we are dealing with airborne isolations, and we should remove it only when we are outside the patient's room. It's a single use. Both of the surgical mask and the N95 are single-use items. Respiratory protective devices designed to achieve a very closed fit and a very efficient filtration of airborne particles. So the N95, it means that this mask, it can filter about 95% of very small particles. Unlike mask, respirator must be fit tested. Before we are using the N95, we should do the fit test. After passing the fit test with the respirator, we must use the exact size, model, and style. We cannot use different types. Seal check should be done every time the respirator is to be worn. N95 mask, respirator, as I said before, it's a single use and to be disposed after patient encounter. In the event of shortage, such as an outbreak or reuse of N95 mask is allowed as long as it remains functional. And in wiqaya, they differentiate between the extended use and the reuse. Extended use refer to the practice of wearing the same N95 respirator for repeated healthcare activities with several patients without removing the respirator between the patient's healthcare activities. And extended use could be implemented when multiple patients are infected with the same respiratory pathogen and patients are placed together in dedicated waiting room or hospital wards or cohorting. But the reuse refers to the practice of using the same N95 respirator for multiple encounter with the patients, but removing it after each encounter. The respirator is stored in between encounter to be put again prior to the extent encounter with patients. But there is restrictions in the extended use. We should wear it only or dispose it immediately when we are doing aerosol generating procedures. We should discard N95 respirator following use during aerosol generating procedures, like taking a swab. And in N95 discard contaminated with the blood, respiratory nasal secretions, or any body fluids. At that time, we should discard it immediately and we cannot use it again. The fit test mask validity is maximum for 2 years. based on MOH recommendations, but the CDC recommend to do it yearly. The fit test must be repeated whenever you have change in your physical conditions, like if you have gained weight or severe weight loss, major dental work, or any procedures in the face of the healthcare worker, or any facial surgery. At that time, we can repeat the fit test. And the healthcare worker unfit with the N95 mask, they should use the powered air purifying respirator or PAPR. PAPR is a battery-operated equipment consistent of half or full face piece, breathing tube, battery, or particulated filter or HEPA filter. We talk about the gown, mask, and goggles. Time of worry surgical mask. What do you mean by time of worry surgical mask? Leila, please, can you ask your questions again? Facial protections. Now we are talking about how we can protect our eyes, nose, and mouth. We should wear eye protections or face shield to protect mucous membrane of our eye, nose, and mouth during activities that are likely to be generate splash or spray, body fluids, or secretion or excretion. Most of our dental doctors, they are using the face mask and the goggles. And if you are exposing to any procedures that may generate splash, we should wear the eye goggles. Protective eyewear are not to be worn after leaving the patient's room, as most of the PPE except the mask nowadays. And we should discard the protective eyewear if it is single use, and if it is washable or reusable, we should wash it as recommended, and we can use it again. Gloves. We should wear the gloves when we are touching blood, body fluid, secretion or excretions, or mucous membrane or non-intact skin of our patient. And we should change it between task procedures on the same patient after contact with potentially infectious material. Leila, she said, I mean, there is specific time, then change average time, how many hours? First of all, nowadays, between patients, we should change it. Between procedures, we should change it. And if it is wet or moist or infected with any fluids. Now we'll talk about the gloves. We should use non-sterile gloves for examination and other cleaning procedures, and use sterile gloves for sterile procedures. We should perform hand hygiene immediately after removal and for sure before wearing the gloves. Remove after use before touching non-contaminated items and surfaces, and perform before going to another patient. Gloves are not to be worn after leaving the patient's room or procedures area. Here we can find the indications for gloving and for glove removal. We can put the glove when we are doing any sterile procedures, when we are anticipating contact with blood or any blood fluids, regardless of existence of sterile conditions, and including contact with non-intact skin and mucous membrane. If we are going to contact with patients during any contact procedures, or our patient is on contact precautions, we should wear the gloves. Remove glove as soon as possible when it is damaged. When contact with blood, any body fluids, non-intact skin and mucous membrane has occurred, and ended, when contact with single patient, surrounding or contaminated body side in a patient has ended. When there is indications for hand hygiene, we should remove the gloves. Here is the pyramid on glove using. First, we will use gloves is not indicated except for contact precautions, no potential exposure to blood and body fluids or contaminated environment, like when we are doing the usual blood pressure monitoring and we are dealing with normal patients, not on any type of isolations, and the skin is intact. We should wear the examination gloves when we are dealing with potential for touching blood, body fluid secretions, or non-intact skin. At that time, we can wear the examination gloves. During any surgical procedures, we should wear sterile gloves. We will stop for a few seconds. Who will answer me? Which glass will fill up first? Number 1, 2, 3, 4, 5, 6, or 7? Did I answer your questions, Layla? 3, 2, 2, 1. 1, 2. I will give you the answer. Together. That means you are not concentrating very well. If we put the water here, it will be closed from here, so it will not be reaching the number 1. Number 2, it's closed from. Number 2 is closed from here. Number 3 is closed from here. Number 4, it's already closed from here. 5, from the beginning, it's closed, so the water will not reach up to 5. 6, there is no pathway. Number 7, it's closed from here. So none of the glasses will be filled first. Okay, we did finish from the hand hygiene, personal protective equipment. Now we are talking about the handling, disposal of contaminated items. Handling or contaminated items will be included as needle, sharp, linen, medical waste, patient care equipment, or lab specimen. Now we will talk about how we can handle contaminated sharps or needle. Handling needles, scalpel, and other sharp instrument or devices carefully. Cleaning used instrument before and after using with approved disinfectant. Disposing of used needles and other sharp instruments immediately. Bags or bottles of IV solutions must not be used as a common source of supply for more than 1 patient. Should be used for only 1 patient. Absolute adherence to proper infection control practices must be maintained during the preparations and administrations of injected medications. Single device vial. Medication packaged as a single-use vial must never be used for more than 1 patient. Multi-dose vial should be assigned to a single patient whenever possible. And don't enter a vial with the used syringes or needles, and never administer medications from the same syringes to more than 1 patient, even if the needle is changed. Please don't recap or manipulate needles using both hands, because this has increased the risk of injury to us as a healthcare worker. If recapping or manipulating is deemed essential, we can use the scoop technique. Don't place used sharp items on any environmental surfaces. Dispose it immediately into an approved puncture-resistant container immediately after use at the point of use, or close the point of use as possible. Close sharp container when it's 3/4 full and remove for proper management. So please remember, 1 needle, 1 syringes, only one time. What we should do when we are handling contaminated linen? Handle, transport, and process used linen in manner which prevents skin and mucous membrane exposure and contaminated clothing. Avoid transfer of pathogen to other patients and other environment. We should place the wet or heavily soiled linen in a designated impermeable bag and close the bag securely, or wrap wet linen in another piece of linen to avoid soaking of the bag. What we should do when we are dealing with contaminated medical waste? We should ensure safe waste management, treat waste contaminated with blood and body fluid excretion as a clinical waste. Human tissue and lab waste that is directly associated with specimen processing should also be treated as a clinical waste, and it should discard single-use items properly. Ensure safe waste management, starting from collection, segregation, until disposal outside the hospital. And as Dr. Ahmed mentioned, the proper design of the medical waste room inside the ICU. We should treat the waste contaminated with blood body fluid secretions as a clinical waste, as written or approved in your hospital policy. Human tissue and lab waste that's directly associated with specimen should be also treated as a clinical waste. We should segregate the different type of medical waste from the point of care or from the point of use into 3 different methods of waste segregations. The black or blue or white for regular waste, the yellow for contaminated with blood or body fluids, the bag for non-sharp, and the container for the sharp objects, the red one for the body fluids. Usually we'll find the red in the delivery area, in the OR, or sometimes in the ICU, but rarely. Securely tie or close the bag container and remove for appropriate disposal. Now we will go to patient's care equipment. What we should do? We should handle equipment soiled with blood body fluid secretions in a manner that prevents skin and mucous membrane exposure, contamination of clothing, and transfer of pathogen to other pathogens or environment. We should clean, disinfect, and reprocess reusable equipment properly before use and also after use. We shouldn't reuse the single-use items. We should discard it immediately. Remove organic material from critical and semi-critical instrument devices using recommended cleaning agents before transfer it to CSSD for high-level disinfection or sterilization. Patient care equipment. Ensure that reusable equipment is properly transported in a leak-proof container to CSSD for reprocessing before use with another patient. When we are dealing contaminated lab specimen, we should wear gloves before obtaining any laboratory specimen. Place it in a designated container with a special biohazard bag and seal appropriately. We should remove the gloves and perform hand hygiene once all lab specimens are in the appropriate container. We should label the container with the appropriate patient's data, transfer to the lab in upright positions to prevent the leakage as promptly as possible. We should ensure there is no leakage in the specimen and the requisitions has complete the information, patient information, as this is critical for lab analysis and clinical interpretations. We are done from the contaminated items. Now we are talking about the environmental cleaning in the ICU. We should, considering the making hand hygiene resources, as mentioned by Dr. Ahmed, the specific design for the ICU and the hand hygiene materials or sink, tissue and mask available in a common area and area used for the evaluation of patient with respiratory illness. We should use adequate procedures for routine cleaning, disinfection, environmental, and other frequently touched surfaces. Rooms should be cleaned daily and after patient discharge. Cleaning is required as per housekeeper policy, but should be observed by the nurses or sometimes the infection control practitioner in the ICU, especially the isolation room. We should use the adequate procedures for the routine cleaning, disinfection of environmental and other frequently touched surfaces, especially the high touch area. Patient placement, where we should put our patient. Single patient's room whenever possible, and most of our ICUs are single patients room. When it is not available, patient spacing should be maintained at minimum of 3 feet or more. Apply appropriate transmission-based precautions. Privacy curtain may be pulled and used as an environmental barrier. Patient placement, it depends on the type of isolation precautions. We have 3 types of isolation precautions: contact, droplet, and airborne. And we will be elaborated more with Dr. Hanan in her lectures. Place patient who pose at risk of transmission to others in a single patient's room when it's available. Food, drinks at workstations or in the ICU. Consumptions of food and drinks in the clinical area with potential for exposure to blood or other infectious material, or where the potential for contamination of work surfaces exists, are prohibited. So there is no food or drinks in the ICU. Water bottle with protective lid properly labeled with the employee name are allowed. So only water are allowed in the workstations. Now we'll talk about the cuff etiquette. Healthcare facility should place acute febrile respiratory symptomatic patient at least 1 meter away from other in a common waiting area, if possible. So if you have a waiting area in the ICU, you should put in your mind all the visitors are following the respiratory etiquette. Post-visual alert at entrance to healthcare facility or the entrance to the ICU, instructing persons with respiratory symptoms or to practice the respiratory cuff etiquette. We should instruct our healthcare worker and our visitors and our patients to cover their nose, mouth when coughing, sneezing with tissue or mask, and dispose of used mask and tissue immediately. Perform hand hygiene after contact with respiratory secretions. Now we will come to the end of standard precautions using surgical mask during certain procedures. We should use a face mask during certain high-risk invasive procedures like central line insertions and spinal procedures. To summarize what we already discussed, we talk about the standard precautions, the definitions, when we should apply it and why we should apply it. We talk about in detail about the 8 components of the standard precautions: hand hygiene, PPE, respiratory cuff etiquette, patient placement, environmental cleaning, and the other component of the standard precautions. So now, can you give me an example of disease that requires standard precautions? HIV, Brucella, HIV, hepatitis, MERS-CoV, all excellent. All disease. As I said before in the beginning of my lectures, we should apply standard precautions in all healthcare settings, ICU, everywhere in the hospital, but we highly recommend to use it in high-risk area like ICU, and we should apply it for all disease with all patients, and regardless of presence of any infectious disease. I think we have time to play a funny game. Please, can you go to this website I will put it in the chat area. You can go to this website. PIN 10. I will write it again. 10504. Good, Faisal. We will see who is the winner for today. I will count just to start. Okay, 5, 4, 3, 2, 1. We will start now the game. Standard precautions. Interventions required for preventing the transmission of disease. First and basic step in breaking the chain of infection in all settings for all patients, all of the above. Which answer is the correct one? All, excellent. Next. Lulwa is the winner. Thank you, Lulwa. Second questions. Standard precautions. 10 component, 8 component, 12 or 6? Diane. Thank you, Diane. You are the winner for the second question. True or false? Hand washing is more effective than hand rub. Place patient who's posed at risk of transmission to others in a single room. True or false? Who is the winner for today? Diane is the first one, the third one. Sarah. Muhammad. Thank you, Muhammad. Thank you, Sarah. Thank you, Diane. Do you have any questions, comment, anything to be added? Any questions? At the end of my lectures, I would like to thank everyone who attended this lectures and give me his valuable time. I know this is maybe most of the few you are attending this lectures for for the only to improve their educations, and maybe I am sure this is from your free time. يعطيكم العافية وشكرا لكم جميعا. I hope I did something good for you and made your day. If you have any questions or comments, I will be happy to share it with you.
Thank you, Dr. Hana, for this interesting and very nice presentation. If there is any question, or we can move to the next lecture. Okay. شكرا ليكي دكتورة هناء.
يعطيك العافية دكتورة. شكرا.
الله يخليك. شكرا. Next lecture will be the principle of aseptic technique and safe injection with دكتور أحمد فاروق. تفضل دكتور أحمد.
السلام عليكم. Welcome back. Voice is clear?
Yes دكتور أحمد. تفضل حضرتك تشير المحاضرة.
Okay, our lecture, our second lecture today, inshallah, it will be about aseptic technique and medication preparation in ICU. So what about aseptic technique? What's the meaning of aseptic technique, and what's the difference between aseptic technique and clean technique? Aseptic technique, as per definition, it is a practice designed to render and maintain objects and areas maximally free from microorganisms and aid in prevention of surgical site, urinary tract, bloodstream, and pneumonia infections. So aseptic technique, as a technique, it is by definition, it is conducted for minimizing or rendering and maintaining area for procedure maximally free from microorganisms and aid in prevention of the healthcare acquired infection in general. Right. This aseptic technique, it involves using barriers such as sterile gloves, sterile gown, mask, sterile drapes to prevent the transfer of microorganisms from care provider and the environment to the patient during procedure being performed. So the idea from wearing this kind of personal protective equipment or barriers to prevent the transmission of microorganisms from the environment and from the healthcare provider to the patient himself. So what about the components of aseptic technique? Components of aseptic technique, it's composed of number one, appropriate attire, hand hygiene, skin and sepsis, single-use device equipment and supplies, and finally environmental cleaning. This is the 5 components of aseptic technique. And thanks to Dr. Hana for his valuable and very interesting lecture. Actually, most of these items were discussed in detail there, but I will focus on some points related to the aseptic technique in ICU. So for the attire as a first part of aseptic technique in the ICU, for the attire, we should select the appropriate attire based on the risk of the procedure that will be conducted and the area of the hospital where the procedure is performed. Risk of the procedure, it means that if I will conduct a procedure with blood or body fluid splash, so I should wear fluid resistant or something to protect my face and my eyes. For example, face shield or eye goggles. If I will conduct a procedure that not requires splashes, so there is no need for the water resistant apron, or I can only wear the regular gown or something like this. Type. What about the area of the hospital? Of course, if I will conduct the procedure in a restricted area in the ICU or restricted area in OR, I should wear a surgical attire or scrub suit or something like this inside the area. So the selection of the proper attire depending on the risk of the procedure that I will perform and the area of the hospital that I will perform this procedure inside. Type. A very important issue. Scrub. The scrub suit, the scrub suit of the OR, it's considered as one of the personal protective equipment, yes or no? Of course, it is not considered as one of the personal protective equipment. It is a regular clothing, okay? But it's not part of the PPE. The PPE, gown, gloves, mask, by different types of mask, face shield, eye goggles, okay? All this considered as personal protective equipment. Scrub suit is not a personal protective equipment. Based on the amount anticipated of fluid, as we discussed before, that you can select either on the type of a procedure that you will do or the area of the hospital that the procedure will be conducted inside. Additionally, some aseptic procedures such as insertion of central line require utilization of sterile gown, as we discussed, and as we will discuss inshallah later in the lecture today. Also, depending on the aseptic procedure being performed, barriers may include gloves, gown, and hair covering according to the type of procedure that you will do. Additional attire, for example, sterile gown, may also be required to maintain a sterile field. So this is as regards the component number one, which is attire, required attire. For the hand hygiene, most of issues related to the hand hygiene already discussed before, but I will just highlight on hand decontamination. It should be conducted prior to any procedure as an integral step of the process. I will give you a summarized table for all procedures that will be conducted inside the healthcare facility, and you will find that hand hygiene is the first step to be conducted, whatever the kind of procedure. Hand hygiene is should be conducted as for any procedure as an integral step of the process itself, as part of the process itself. Important issue we should highlight that long natural fingernails, artificial fingernails, or any fingernails enhancement should not be worn by direct care provider of high-risk patients, for example, ICU, OR, oncology, and neonatal. So long natural fingernails is not accepted. Artificial fingernails is not accepted. Any fingernail enhancement should not be worn, especially for ICU, OR, oncology, neonatal, high-risk areas that have vulnerable patients, as there is a risk of some microorganisms can be hide below these fingernails or extenders, and it will be difficult to be cleaned and disinfected. So this is the second part of the skin antiseptic. Let's move for the aseptic technique. Let's move to the third component of aseptic technique, which is the skin antisepsis. It's very important to use the appropriate recommended antiseptic for each procedure type, as well as screening for contraindications such as allergies and age limitation. What's the meaning of this? It's very important to make in your mind or in consideration when selecting the antiseptic, the type of procedures that you will do. Number one, if you will insert central line, you will select certain aseptic technique and skin antisepsis. For example, chlorhexidine with alcohol. If you will prepare a patient for a surgical intervention, you will utilize another skin antiseptic with another concentration, for example, betadine or chlorhexidine alone, according to the type of procedure. This number one for selection of skin antisepsis. Number two for selection of skin antisepsis, contraindication or allergies that could occur. For example, chlorhexidine, as you know, it's not allowed to be utilized for the neonates, okay, as it can cause a severe skin allergy for this category of patients. So chlorhexidine is not allowed or not encouraged to be utilized for this kind of babies, for neonates, okay, and you can utilize another skin antisepsis. Some of the adult staff or some of adult patients have some kind of allergy against some skin antisepsis. Some of them are suffering from allergy against iodine. So you should screen the type of patient or ask the patient if he have suffering of any type of skin antisepsis before its use. So before selection of skin antisepsis, you have to make sure that number one, you are selecting the antiseptic according to the type of procedure that you will perform. Number two, there is no contraindication or allergy of the patient between to this antiseptic. Antiseptic agent should be used with the following manufacturer direction for use, including ensuring skin is clean before placement, as well as antiseptic contact and drying time. And here it's very important. We are observing, unfortunately, some of the staff is just performing skin antisepsis, for example, iodine, and putting the iodine and without waiting for being dry, just drying with tissue and start the procedure immediately. This is wrong. This is not applying the skin antiseptic. Skin antiseptic, in order to be applied properly, you should take in consideration that manufacturer recommendation for dilution, if it's required to be diluted, or it can be utilized as it's ready to use. Number two, skin is clean and there's no visible dirt or skin, and there is no visible any visible contamination before applying this antiseptic, as this is antiseptic, not a detergent. There is a difference between detergent and antiseptic. Detergent, it is a soapy material, can be utilized for removing dirt. You can use it for washing skin, removing dirt from the patient before applying antisepsis. But make sure that before applying antiseptic, skin is clean and dry. Skin is clean and dry. If you you have to utilize detergent to remove dirt from the surface of the skin, you should make sure that the skin is dried well before applying the skin antiseptic after utilizing the skin detergent. Okay, this is very important. So again, for skin antiseptic, you should select it according to the procedures that you will do. You should make in consideration if there is allergy to the patient that you will apply skin antiseptic to his skin, yes or no. And also you should apply the skin antiseptic according to the manufacturer recommendation for the required dilution, and you should make sure that the skin is clean before applying the skin antiseptic and dry. And the final point, which is very, very important, and unfortunately it's common mistake, let it dry according to the manufacturer recommendation. Don't put iodine and dry it with tissue and immediately after applying in order to start your procedure. This is not a proper practice. Okay. Right. Let's move to another component of skin antisepsis or antiseptic technique: single-use device and equipment and supplies. Personnel should maintain the sterile packaging and or container integrity to ensure an intact seal and confirm that the sterilization indicator with expiration date if provided are verified. Let's understand or simplify this sentence. Any candidate that you will start your procedure, whatever the procedure, insertion of central line, you will start surgical procedure, wound debridement, whatever, in the ICU. First thing before starting the procedure is to prepare your equipment or supplies. If you have within these supplies a sterile package, you should make sure that this sterile package, container integrity is maintained. There is no puncture, there is no visible stain present, there is no dust accumulated, seal is intact, okay, and finally it's not expired. This is very important parameters to be checked before starting your procedure. If you didn't check this, if the package is not maintained, package integrity is not maintained, if there is any fissures or any leakage or any cut in the envelope of the sterile package, it's not sterile anymore, and you can expose your patient to risk of acquiring infection. So this is very important to personnel should maintain sterile packaging or container integrity before the procedure, checking it's intact, checking its sterilization indicators there and its SPAS and expiration date, and there is no stain or visible dust or something like this accumulated on the outer surface of the sterile packaging. The items also, including solution, should be aseptically transferred to sterile field. It should be aseptically transferred. What's meaning by this? For example, if you have a betadine bottle and you will pour some of this betadine to disinfect the skin of the patient before insertion of central line, you should make sure that there is no touch technique utilized during pouring of this amount of betadine from this bottle to the cup or to the containers that you will use for the skin preparation or something like this. no touch technique. You should maintain it aseptically transferred to a sterile field. Okay, this is number one. When you will transfer this from the cup or the container that you are putting this betadine inside to start to prepare skin of the patient for antiseptic skin preparation, you should be sure that you are utilizing sterile dressing and sterile tool for holding this dressing for starting to soak it inside the betadine and start to paint the skin of the patient by this antiseptic. Okay, so this is the meaning of aseptically transferred. Aseptically transferred, that you are transferred from the bottle to the container in not without touch, in non-touch technique. Okay, number one. Number two, you should transfer it or from this container to the skin of the patient utilizing sterile gauze or sterile dressing, and also you are holding with tool which is sterile. For example, forceps or something like this to start the skin preparation. Again, what's very important, don't reuse single-use items. It's not allowed. If it's mentioned it is as a single use, so it is a single use. Don't reuse it, okay? Reusing a single-use item, it's allowed in certain situations according to some regulations will be agreed upon in the infection control committee, but it's not as a regular or it's not as a usual practice. Usual practice, don't reuse any single-use item. Okay, for the final issue related to the aseptic technique, which is the environmental cleaning. Environmental cleaning, as Dr. Hana discussed with us during the standard precaution lecture, clean and disinfect the environment surface using MOH approved disinfectants. It's very important. And of course, you should utilize the disinfectant according to the purpose that you will utilize for. For example, if you are utilizing disinfectant for the floor disinfection, it's totally different than the disinfectant that you are using for the surface disinfectant or something like this. So what's the meaning of disinfectant and antiseptic? Disinfectant and antiseptic solution. Both of them are solution. Disinfectant, it's this terminology is means that the chemical used for environment disinfectant. If you are talking about chemicals that is used for the skin preparation or used for the hand antiseptic preparation or something like this, it's called antiseptic. So disinfectant chemical used for the environment, antiseptic solution, it's the chemical used for the skin preparation or human tissue. Okay, for example, for the quaternary ammonium, for example, quaternary ammonium, it's used as a disinfectant, not antiseptic. Okay, but we have a betadine. Betadine, it is not a disinfectant, it is antiseptic solution. So this is the difference between disinfectant solution and antiseptic solution. Of course, we have to use a clean equipment and supplies, for example, mops, water, cleaning clothes for environmental hygiene. This is very important to utilize this kind of clean equipment or clean supplies for environment cleaning disinfection. There is a question here for what's the best skin antiseptic in neonates. Best skin antiseptic in neonates, we are utilizing alcohol for the skin preparation or betadine in low concentration. Okay, but chlorhexidine in neonate, it's still questionable, and still there is a lot of guidelines don't encouraging utilizing it, as there is a lot of recorded event of allergy, especially for the neonatal skin. So this is for the aseptic technique. Let's move to another technique utilized in the ICU, which is the clean technique. Clean technique, aseptic technique, of course, most of it will be with sterile gloves or something like this. But here for clean technique, we are using clean gloves. Clean technique, we are using clean gloves instead of sterile gloves. May be worn after hand antisepsis in most instances where clean technique is indicated, although sterile gloves should be used for sterile dressing application. It may be a little bit confusing right now for the clean and the sterile technique, but I will clarify in the next slides, inshallah, with the table. But till now, aseptic technique, we discussed it, aseptic technique with its component. Clean technique, we are utilizing clean gloves after performing hand and sepsis, and still we can utilize sterile gloves only for sterile dressing application. Sterile dressing application. So you are meaning that sterile dressing application can be done under clean technique? Yes, and you will discover it later, inshallah, how it's a sterile dressing application can be done with clean technique. The no-touch dressing technique should be used to prevent the contamination of sterile dressing depending on the type and extent of the procedure. So here we are, the idea behind the clean technique and the sterile dressing implementation or application. The no-touch dressing technique should be used to prevent the contamination of sterile dressing. What's this meaning? No-touch technique, it means that you are holding the dressing with a sterile dressing tool in order to apply to the wound, for example, for performing the wound dressing. Okay, this is sterile dressing, and you are not touching this sterile dressing by your clean gloves, but you are touching with a sterile tool. This sterile tool, it's touching sterile with sterile, it is still sterile. But if sterile touched with clean, it will be converted from sterile to clean. This is the rule of the sterilization. Sterile surface with sterile surface, still sterile. Sterile surface with clean, it is a clean surface. Okay, so here you are adopting clean technique, but you will apply sterile dressing to the wound for the wound dressing change, but without touching this sterile dressing. You just will touch this sterile with a sterile tool to put it on the wound, and then applying the adhesive plaster tape later on. Use clean gloves for routine changing of surgical side dressing, as we discussed before, tracheostomy care and maintenance of intravascular line, as long as you use techniques that prevent the transfer of new organism or movement from one side to another, and utilizing the no-touch technique, as we discussed before. Clean gown should be worn to minimize contamination of clothing, following standard precaution guidelines, as we discussed with Dr. Hana in the previous lecture. So what about surgical aseptic technique outside the OR? Surgical aseptic technique outside the OR. There is surgical aseptic technique outside OR. Yes, some minor procedure or minor surgical procedures that can be conducted outside the OR. It should not, the patient should not be transferred inside OR for just wound debridement or simple wound debridement, something like this. This is called surgical aseptic technique outside the OR. Setting outside the OR may not have the capacity to follow the same strict level of surgical asepsis applied in the operating room. So in this situation, I don't have red lines, and I don't have a restricted area and semi-restricted area like what present in the OR. So what I should do, you should utilize what's called environmental controls. What's the component of these environmental controls? Number one, use of special treatment or operating rooms. Managing activities to reduce airborne transmission if procedures are performed at bedside. Number one, use of special treatment or operating rooms. It means that in the ICU or in the admission ward, you should have a room called minor procedure room. This minor procedure room, as much as you can, you should make it positive pressure, equipped with surgical light, and also equipped with surgical hand scrubbing sink in order to perform surgical scrubbing before the procedure. This is called special treatment or minor procedure room. Managing activity to reduce airborne transmission if procedures are performed at bedside. If you don't have this procedure room, at least if you have again, if you have a procedure room, it's the best to perform the procedure inside this procedure room. If you don't have a minor procedure room inside, you can utilize it in bedside, especially if it's life-saving or life-threatening situation and should interfere immediately. You should do bedside procedure, but you have to manage activity, prepare everything, wear the required personal protective equipment, keep the room door closed during the procedure, using physical barriers such as screens or something like this in order to decrease the risk of contamination to the patient procedure, diverting traffic in the open units to be away from the procedures that you are performing, excluding visitors and unnecessary personnel, trying to minimize people as much as you can. If you have a lot of people present inside the patient room surrounding the procedure, there's the risk of infection can be very, very high. So you should minimize the number of people as much as you can, avoiding cleaning activities in the invasive procedure in order to not to disturb the dust on the floor, to decrease the number of microorganisms that can reach to the patient wound, and also providing additional environmental control such as ventilation to further reduce the contamination. So all of these are considered as measures for decreasing or minimizing the risk of infection if you are performing surgical aseptic technique outside the OR. So the best one is to perform in the minor procedure room. If you are not able to perform in minor procedure room, you should perform it beside in the patient room, bedside procedure. But if you will do it, you have to prepare everything, keep door closed, use physical barrier, and also diverting traffic, excluding minimize number to the as much as you can, avoiding cleaning activities in the area, providing additional environmental control such as ventilation to further reduce contamination. So let's move to the example, and this will answer the question here. So clean wound is not a aseptic technique procedure. No, it's a aseptic technique procedure, and I will give you the idea behind this sentence. For example, the hygiene indicated, yes, it will be part of all the procedure. Any procedure that we will discuss in these tables, it should be started with hand hygiene. So number one, for wound cleaning, you should perform hand hygiene. Type of personal protective equipment to be used: clean examination gloves and personal protective equipment as appropriate according to the procedure as we discussed before. Supplies in time, sterile wound cleanser, sterile supplies such as cotton applicator or gauze or something like this in order to apply the sterile dressing without touching this sterile dressing by the clean gloves that you are wearing, okay, to maintain the aseptic technique. Irrigation performed with sterile device with maintaining a clean technique. This is very important. So here as instrumentation, we are depending on clean technique, not a sterile technique. Clean technique, not a sterile technique, okay? So again, for wound cleaning, we are having two types of aseptic technique. This is the highest one, and we have a clean technique. For wound cleaning, we are depending on clean technique. So clean examination gloves and personal protective equipment as appropriate. Supplies indicated: normal saline or prepared sterile wound cleanser, sterile supplies such as cotton applicator or gauze, and irrigation performed with sterile device while maintaining clean technique. You got the idea that you have a clean gloves, but you are holding applicator sterile in your hand. This applicator will touch the sterile gauze to put the sterile gauze or sterile dressing on the wound in order to change the wound dressing. So here we are talking about clean technique, okay, but we are using sterile gauze or sterile dressing. Type. This for the wound cleaning. For routine dressing changes without debridement. Routine dressing changes without debridement. Again, we are utilizing clean technique, clean examination gloves and personal protective equipment as appropriate, sterile supplies using clean technique, sterile supplies using clean applicator or clean technique as we discussed in the same as wound cleaning. For dressing change with mechanical or chemical or enzymatic debridement, again, still we are following the clean technique, okay, using clean examination gloves, personal protective equipment as appropriate, sterile supplies using clean technique, and sterile supplies using also the clean technique. Type. For repeating the clean technique again, I will just summarize the clean technique again to just try to simplify it. Aseptic technique, as we discussed before, aseptic technique, it's related to decreasing the microorganism as much as we can. And the aseptic technique, mainly for insertion of central line or insertion of something like this. This is the aseptic technique. Tamam? Type. For the clean technique, it's depending on utilizing clean gloves instead of sterile gloves, may be worn after hand and sepsis, and you should perform no touch technique during dealing with the clean technique in order to not contaminate sterile dressings that you are utilizing. and using clean gloves for routine changing of surgical side dressing as we discussed before. Clean gown if it's required. طيب, I will show you slides that will make it easy for you for differentiate between clean and sterile supply procedures. For the medical asepsis or clean technique, okay, it is a procedure in which an instrument come in contact with intact mucous membrane. For example, bronchoscopy, gastrointestinal endoscopy, tracheal suction, peripheral intravenous insertion, urinary tract catheterization. All of these are considered as a clean procedure, medical asepsis, not a surgical asepsis. For the surgical asepsis or sterile procedure in which the instrument goes through sterile tissue or fluid, the central venous line insertion, central venous line wire insertion, or cardiac pacemaker insertion, or arterial line insertion. All, if you have invasive procedure, it is called an aseptic technique or surgical asepsis. If you don't have any of this invasive procedure, you will not invade intact skin or intact mucous membrane. So in this situation, a clean technique can be applied. Okay, طيب, let's return back to the examples here. Wound cleaning. Wound cleaning, it is a clean technique. I'm not invading any skin surface or something like this. It's already open. Okay, so you should apply utilizing clean technique and apply sterile with no touch technique. You should apply sterile dressing, catching this with applicator, sterile applicator, and catch the sterile dressing and apply to the wound without touching the sterile dressing itself by your hand, which is wearing clean gloves inside. If you are routine dressing changes without debridement, it's the same. Routine dressing changes without debridement, you will do it as the same. Clean examination gloves, personal protective equipment, sterile supplies, again as we conducted in the wound cleaning, without touch, with no touch technique at all, and then apply the sterile dressing with a sterile applicator. If you are dressing change with mechanical, chemical, or enzymatic debridement, that you are performing wound debridement by mechanical or some enzymatic debridement, for example, hydrogen peroxide water or something like this, just pouring without touch. Okay, make sure it is conducted aseptically, and you are performing clean examination gloves, personal protective equipment, sterile cleaning, regular wound cleaning. So again, for wound cleaning, clean technique. Routine dressing change without debridement, it's still clean technique. Dressing change with mechanical, chemical, or enzymatic debridement, there is nothing invasive till now. All of these procedures are considered as clean technique. I'm not conducting any invasive procedure. I'm not invading the skin or the mucous membrane. Right. If we are changing the step to dressing change with sharp conservative bedside debridement, I will perform bedside debridement. I will cut the skin. I will cut the tissue. In this situation, I will start to invasive procedure. So here we should wear sterile technique. We should adhere to the sterile technique or surgical asepsis. In this situation, I will handle my hand inside the wound itself. So I should wear sterile gloves, personal protective equipment as appropriate, sterile supplies, sterile technique in order to perform it. So here we are starting to perform invasive procedure. Dressing change with sharp, conservative bedside debridement. Here, sterile line dressing change. Sterile line dressing change. Okay, sterile line dressing change. We should follow sterile supplies. Again, we are invading the skin, invading the mucous membrane. So we should adhere to sterile technique. Tracheal suctioning, where the tracheal suction catheter is not within a closed sheath, it is an open suction method, okay, not a closed suction system. So in this situation, lung itself inside the lung, okay. So here I should wear sterile gloves, use personal protective equipment, sterile suction catheter, and it should be single use, and also sterile technique. Okay, tracheostomy care or suction with a suction catheter with a closed sheath, clean examination gloves, and here I can go for the clean technique. طيب, يبقى again for the clean and sterile technique. I know it's a little bit confusing, but I will try to simplify it. If you are invading the skin or mucous membrane, so it is a sterile technique, sterile or surgical asepsis. If you are not invading the skin or mucous membrane, it is a medical asepsis or clean technique. Okay, wound cleaning without invasion, regular wound cleaning with just pouring some sterile fluid in the wound, okay, with aseptic technique, it is called clean technique. Routine dressing change without debridement, we should follow clean technique. I'm not invading the skin, okay. If you are invading the skin for dressing, if you are invading the skin, you are invading the skin for dressing change with sharp conservative bedside debridement, it is a sterile technique. If you are inserting central line dressing, it is a sterile technique. If you are performing tracheal suction with open suction system, not a closed, it is a sterile technique. Okay, this is the idea behind the sterile and the clean. This slide is simplifying the issue. If you are invading the skin and the mucous membrane, it is a surgical asepsis. If you are conservative, not invading the skin or mucous membrane, it is medical or clean procedure. So this is for the aseptic technique. Let's move for the medication preparation. Medication preparation, it is a separate clean area. It should be conducted in a separate clean area in the ICU, as we discussed in the medication preparation in the ICU before. In section, you should prepare a room for medication preparation. So it should a separate clean area is available for dedicated place for ready-made single dose sterile solution as much as we can. Ready-made single dose, it will be the best to avoid contamination, avoid cross infection, avoid transmitting infection between patients in the ICU. So if it's possible, use only ready-made single dose sterile solution. Single dose or single use vial is used for a single procedure injection in a single patient. Okay, single dose or single use vial is used for single procedure, as we discussed in details with Dr. Hana in the previous lecture. For safe injection practice, single dose or single use, it should be for single patient or single procedure. It's not stored, and single dose or single use, it should not be stored for future use even on the same patients. It should be used for this patient. Once opened, any remaining portion should be discarded. Okay, if it's single dose or single use vial on the same patient. But if it's single dose or single use vial, it's not allowed to be stored. Once opened, the remaining portion should be discarded. For example, heparin ampoule or something like this. Once opened, it's not allowed to be kept beside the patient. Not in syringe, not in the same ampoule after opening. It's not allowed. Just open, take the dose, and the remaining portion should be discarded. This vial is used for single patient with recorded patient name and date of the first use. Multi-dose vial. If it's opened, for example, if you are talking about ointment tube or eye drops bottle or something like this, it can be utilized for 28 days unless it is mentioned something else by the manufacturer. If nothing specified by the manufacturer, it can be accepted till 28 days. Provided that it's used for the same patient, okay, for the same patient, not multiple patient, and follow non-touch technique during implementation. So it's not allowed that you are utilizing eye drop bottle to multiple patients. You will transfer infection to them. If you are performing eye dropping to the patient and you touching with this bottle the patient eye himself, you should discard this bottle. If non-touch technique is not maintained, the bottle should be discarded immediately, not to be kept even for the same patient. If a multi-dose vial is used for more than one patient, it is exclusively kept and accessed in the area specified for the preparation of medication. If multi-dose vial is used for more than one patient, it is exclusively accessed in the area specified. Medication room, for example, not allowed to. If you obliged to utilize multi-dose معلش عذرا النت فصل. طيب again for utilizing a multi-dose vial, it's used for more than one patient. It's exclusively kept and accessed as we agreed in the medication room. It's not allowed to access it beside the patient bed itself. The cartridge device such as insulin pens are used only for one patient. Under any circumstances, it's not allowed to utilize a cartridge pen or cartridge device, for example, insulin pen for more than one patient. It's only one patient, whatever the situation. Self-sealed rubber cap of medication vial or IV solution bottle is disinfected with approved antiseptic wipes, alcohol wipes prior to any access. If you are just keeping it for multi-acts of the patient, you will prepare multi-doses for multiple patients for multi-dose vial. You should make sure that alcohol disinfection of the rubber every time that you will access this bottle, and very important to leave it to dry before accessing this bottle each time. IV solution bottles are only accessed through the self-sealed rubber cap after being disinfected. As we observe, it is a common mistake that especially the IV solution bottle to be accessed from the side, to be accessed from the bottom to insert a needle inside this plastic IV bottle solution, especially when connected to IV line to the patient. This is very not correct or totally not accepted procedure. IV solution bottle should be accessed only through the self-sealed rubber cap. As it's mentioned, as what's mean here, self-sealed. Once you remove the needle, the rubber cap will self-seal again, will close itself again. Okay, so IV solution bottle only accessed through this self-sealed rubber cap. IV sets that are used to administer blood and blood products will be replaced every 4 hours. If you are utilizing IV set, the IV line, or here we are talking the line, the bag itself and everything. If you are utilizing the IV set for administer blood or blood products to the patient, should be replaced every 4 hours. If you are utilizing this IV set for transferring lipid emulsions or dextrose or amino acid or TBN solutions to this patient, it should be replaced within 24 hours of initiation the infusion. This is because that increasing the amount of hours rather than this limit, it can expose the patient to risk infection transfer even you are keeping closed circuit. So again, for the blood and the bloody fluids, for the blood and the blood products, it should be replaced every 4 hours. For the lipid emulsions, dextrose, amino acid, or TBN, it should be replaced every 24 hours, not more than this. For sterile solution are used in nebulizer, humidifier, or any aerosol generating system and changed between patient and every 24 hours for the same patient. Again, sterile solution are used in nebulizer or humidifier or any aerosol generating system and changed between patients. If it should be changed between patients and every 24 hours for the same patient unless the manufacturer of ready-made sterile solution specifies different dates. Sterile solutions used for nebulizer or humidifiers should be changed between patients. If for the same patient, not more than 24 hours. Okay. Peripheral venous catheter must be properly fixed with the clearly written dates. It's very important to mention the date and hours of insertion, and to reduce the risk of infection, as it should be maximally replaced every 72 to 96 hours, every 3 days to 4 days, not more than this. Okay, every 3 days to 4 days. So the peripheral inserted cannula, it should be replaced every 72 hours, which is 3 days, to 96 hours, which is 4 days, to 3 to 4 days. This is the maximum allowed time, not every 24 hours, not every day, not every week. This is the accepted duration. 96 hours, this is the GCC guidelines. 72 hours, this is the CDC recommendation. Okay, so between 72 and 96, this is the allowed duration to replace the peripheral venous catheter. So again, for the medication preparation, safe injection practice, as we discussed in details before. And for the important points, we have to highlight that IV set for the blood and the body fluid should be replaced every 4 hours. And for the IV set for the lipid emulsion, dextrose and TBN should be replaced not more than every 24 hours. And for sterile solution, it should be replaced between patient. For the same patient, it should be replaced not more than 24 hours. And for the peripheral venous catheter, may be properly fixed with a clearly written date and time and hours, as we discussed before, and not be replaced not frequently more than 72 3 days to 4 days. This is for the aseptic technique and the medication preparation. I know it's a difficult topic, and I try to make it simple as much as I can to avoid confusion between both examples of clean and sterile supplies. I'm ready for any question if you have any question for discussing. Any question? Thank you all for your time, and I actually am very happy to attend with you this valuable lecture. And I tried my best to simplify the difference between the clean and the aseptic technique. I know it is a little bit confusing for the first time, but I believe that for hearing the lecture in the record and for reviewing these examples in the table, it will make it more easy and simplify the issue, inshallah. Again, if you have any question, if you can share with the organizing committee, and I will be happy to answer it later, inshallah. Thank you all, and I hope great lectures and a great course for you.
Thank you, Dr. Ahmed, for this valuable information. And now lectures of principle of environmental cleaning and disinfection in ICU. It is my pleasure to present my colleague, Dr. Sameh Tawfiq, Infection Control Specialist in General Directorate of Infection Prevention and Control, Ministry of Health. He will discuss the principle of environmental cleaning and disinfection in ICU as one of critical hospital area. Dr. Sameh, اتفضل.
السلام عليكم. Thank you, Dr. Hanan, for introducing me. I'll not repeat my to get you to tell my name again, but I'll start rapidly for this important topic because I think this lecture may be somewhat long. Environmental cleaning and disinfection in ICU. This topic nowadays is very important, and my lecture will concentrate in say 3 sectors. First sector, I have to make you convinced that the environmental cleaning in ICU and generally in healthcare setting is very important. And the importance of environmental cleaning and the role of environment in prevention of hospital-acquired infection maybe nearing the importance of the proper hand hygiene practice. Okay, let us start. I'll start by this photo. This photo is not regarding my lecture, but I like this photo very much because this photo shows us that we are heroes. I think all of us, we know that we are heroes facing these infectious agents and infections. Thank you for all healthcare workers. Condense my lecture. I start with introduction and then I'll jump to the role of environment in transmission of infection. And after being convinced, we will go to the activities we have to do to mandate the environment in our health setting and in ICU clean and safe. Safe for the patient and also for healthcare workers. Then I'll go to area decontamination. Area decontamination could be manual or could be using new technologies. Lastly, I'll talk about monitoring of the quality of environmental cleaning. As any behavior or any activity in healthcare, we should monitor the quality of this practice. How to monitor the quality of environmental cleaning and be sure that the environment is safe. As introduction, healthcare workers facing a number of serious safety and health hazards. This will include bloodborne pathogens and biological hazards and potential chemical and drug exposure and infectious waste and a lot of hazards. Healthcare facility environment should be maintained clean and safe for patients and visitors and healthcare workers. Again, I'm talking about ICU, I know, but really environmental cleaning and the safe environment should be shared in all the healthcare setting, in every area where is a patient to be cared. Presence of bacteria in the environment is inevitable and is not practical or possible to eliminate these bacteria completely. This is very important to know. All of us must know that we can't eliminate completely the microorganisms from the environment. We should have some environment, some microorganisms, but our rule to discard or to get out from the pathogenic microorganisms and minimize the microbial load on the environment of the care in ICU. All healthcare workers should share in application of environmental cleaning policy. Environmental cleaning, it is not the role of only housekeepers. It is the role of all healthcare workers, and we will show that. Environmental cleaning is an important part of breaking a chain of infection and preventing cross-contamination, that may cause hospital-acquired infection. And hospital-acquired infection in a department, critical department like intensive care units, I think it will be critical for the life for the patients. Well, I'll start with historical perspective. This is historical. There is an opinion, this opinion, old thinking, that the environment is not playing any role in transmission of hospital-acquired infections. And the only rule and the major rule for transmission of hospital-acquired infection is coming from hands of healthcare workers. I know this rule is somewhat right because hands of healthcare workers usually is responsible, if not washed or cleaned or properly, can transmit infection to the patient. But the environment playing a great role, and we will see how the environment play a great role in transmission of infection and makes the hospital-acquired infection could be transmitted through the environment to the patient. Nowadays, our latest thinking, and there is many researches every day, prove that the role of the environment is so great in transmission of infection. For me, now, after a lot of researches and published literatures, I found that the hospital environment or contaminated environment in departments like ICU playing a great role in transmission of hospital-acquired infection, equal maybe or more to the hand contamination. Okay. What is the process by which an environmental contaminant is transferred to another surface? Healthcare worker or patient to cause the infection. This is give us an idea how the pathogen or the organism or the environmental contamination can play a role in transmission of hospital-acquired infection. How? It needs the surface, environmental surface must become contaminated by airborne or contact or droplet or another, it is contaminated. This contaminated surface have microorganisms, and these organisms should be survived. And the survival of microorganism needs many rules. First rule, this surface couldn't be cleaned or disinfected properly. And this surface should be must be touched by the hands of healthcare workers or the patient itself. And the person must transmit the organism from hands to another person or to the patient, or from hands of the patient to the port of entry to transmit the infection. I like this slide very well because this can give you all the idea. First, we have the infected or colonized patients in our department. Usually, we have an infected patient or colonized patient, colonized with pathogenic microorganisms. This patient is admitted in the department, in the ICU, lying in the bed in one room. And the environmental surfaces around this patient will be contaminated or considered to be contaminated by the same pathogens from that infected or colonized patients. And also, here is the role of the environment. If that patient discharged or transmitted to another room, and a new miserable patient come, and there is no proper environmental cleaning, and the new patient can get the infection from the contaminated environmental surfaces. This is a direct way. Or also, we as healthcare workers, during providing care, touching the contaminated environment around that infected or colonized patient, and without proper hand hygiene practice, I can go to contaminate the patient or transmit the infection to the other patients. This is the chain of infection, and this is the rule how the environment or contaminated environment playing a great role in transmission of infection. This is chain of infection. Look, we can break the chain by proper environmental cleaning and the terminal cleaning. This prevents the transmission from the contaminated environment to the new patient, or prevention of contamination of hands of healthcare worker during providing care to that patient. And also hand hygiene should be mentioned here, because hand hygiene preventing the transmission through the contaminated hands to the other patients, a new patient to get the hospital-acquired infection. This slide is the same. Contaminated surface or equipment. The infected or colonized patient can contaminate the air. It can direct contaminate the other patient by contact, or contaminate the environmental surface and contaminate the hands and go to susceptible patient to acquire the hospital-acquired infection. This also explains what we said, environment to hand to patient. As we said, contaminated environment can contaminate the hand and transmit the contamination or infection to another patient. What is the environmental surfaces in our department, in ICU? What is the environmental surfaces? Environmental surface could be floors, walls, beds, bed rails, bedside tables, bed curtains, doorknobs, maybe remote control, maybe telephone if the patient conscious. And also reusable medical equipment could be considered as environmental surfaces like monitors. This is commonly touched surfaces in a room, a patient room in ICU. We know the monitor is commonly touched. The monitor is not commonly touched by the patient, but commonly touched by healthcare workers, and healthcare worker hands could be contaminated. From where could be contaminated? I think all of us, we have a great importance to practice hand hygiene. All of us know how to practice hand hygiene. All of us, we are properly using alcohol gel before entering the room of the patient. But once touched the doorknob, you acquire the contamination from the doorknob. You are thinking that your hands are clean and safe, but you acquired an infection from the doorknob. You have to think about, all of us, we have to think about the doorknob. The doorknob plays a great role in contamination of hands of healthcare workers. Some companies produce a product, electronic machine, small machine fixed above the doorknob after opening the door and close it, it will make a splash of disinfectant to the doorknob. This shows us what is the great importance of the doorknob in contamination of our hands. Okay, and also bed rails. All of us, while talking with the patient or seeing the patient or observing the monitor or observing the patient, involuntarily we are touching the bed rails. Okay, all of these environmental surfaces could be contaminated or should be contaminated by the same pathogen from the patient. Also, we have to talk about the bedside curtains. Bedside curtains are very important issue. Also, we ignore the role of bedside curtains in contaminating the hands of healthcare workers. The same idea of the doorknob. If we go to the patient and before going to the patient area, we are practicing properly hand hygiene by alcohol hand rub, okay? And go to the patient and using our hands to move the bedside curtains. There is a research give information that bedside curtain, contaminated bedside curtain can contaminate 50% of hands of healthcare workers. As we know, contaminated hands can transmit infection for the patient, for these patients. Okay, bacteria and the fungi can survive on the bedside curtain, okay, and for long time can survive. But we have to know and talk about the time of survival, the survival time of the pathogens or microorganisms on the in the environmental surfaces. Actually, it is a multifactorial process. For any organism to live on environmental surface, this is multifactorial process. It depends on the microbe itself. The microbe itself, not all microbes have the same time it can live outside the susceptible hosts. It depends also on the temperature. Temperature, if high, some microorganisms can multiply rapidly and survive on the high temperature. Also, humidity play a great role in multiplication of microorganisms. If the surface is smooth or have pores, surface should be cleaned and disinfected. Corrugated surfaces, surfaces with pores like marbles, closed surfaces. Okay, so we don't like closed surfaces in ICU because it will harbor the infection inside and we can't clean and disinfect. All these factors can affect the survival of microorganisms in environmental surfaces in ICU. This table shows us that the organisms can survive for, some organisms can survive for long time, some for short few hours and some for long time if they are affected by a proper environmental surface disinfection, cleaning and disinfection. Okay, all of this give us an idea to prove that the environmental contamination is very important and playing a great role in transmission of hospital-acquired infection. We finished first part in our lecture and we'll go to, we know the problem. Now we know we have to go to the solution of the problem. Activities we have to do to mandate the environment clean and safe for patient and healthcare worker. What is these activities? First, we have to know what is the definition of some terms. What is meant by cleaning? Cleaning, it is a removal of visible soil, dirt, organic and inorganic material. And what is the importance of cleaning? Importance of cleaning is very important because if you are not clean the surface before applying disinfection and there is a visible dirt, organic or inorganic material, it will make a barrier between the disinfectant, whatever the potency of the disinfectant, what is the level of disinfection process used, it will be make as a barrier. Barrier prevent the disinfectant from reaching that area covered by a visible soil or organic or inorganic material. What is the disinfection? Disinfection describes a process that eliminates many of all pathogenic organisms except the spores. Why we told except the spores? Because disinfection, we cannot eliminate all microorganisms or pathogens. Why? Because this will be a sterile process, sterility. And we never be able to make the environment sterile. The environment couldn't be sterile. Environmental surfaces couldn't be sterile. Many of products can tell you sterilize your hands, sterilize your environmental surfaces. No, this is wrong term because all these couldn't, hands and environmental surfaces couldn't be sterilized. That's why we tell cleaning and disinfection. And in infection control, when we told environmental cleaning, we are meaning environmental cleaning and disinfection. Cleaning is required before disinfection because inorganic and organic materials that remain on the surface that interfere with the effectiveness of the disinfection process. And also if the soiled material will be dried, it will be so difficult to be removed after that. If we have soiled organic material or soil on this environmental surface and we let it to dry for a long time, this will be so difficult to be removed. Okay. We'll go to the types of environmental cleaning. Types of environmental cleaning, we have 5 types of environmental cleaning. First, what is called scheduled cleaning. Second is an emergency cleaning. Third is a project cleaning. Fourth is a terminal cleaning or area decontamination. Fifth is the blood and the body fluid spill cleaning. We will talk rapidly about each type. But first, we have to talk about the equipment and the PPE used during cleaning. It's very important. We have to use equipment for cleaning. For cleaning of environmental surfaces, we have for the floors and walls, we have to use double or triple bucket technique. Double or triple bucket technique is a term to mention the you are using double technique or triple. Double is disinfectant and water. One water and one disinfectant. And the triple is one water and one detergent and one disinfectant. Let us to know something very important. Cleaning is essential component should be done by friction. We can't clean without friction. You have to move your elbow. You have to move the wipe on the surface. Never to mention cleaning by something to spray. It is not a cleaning. Cleaning, you have to rub the surface, to wipe the surface hardly, to remove any soil, because you are talking about soils. You have to remove that soils hardly by using water and detergent, by using friction methods. We'll start by scheduled cleaning. Sorry. Scheduled cleaning, it is that cleaning done by schedule. This describes the daily cleaning. I know in ICU, which is a department for 24 hours, maybe every 8 hours we have scheduled cleaning. And this scheduled cleaning is in a certain time with checklists to clean every surface which is called commonly touched surfaces. We will concentrate on commonly touched surfaces in this scheduled cleaning. We'll clean the bed, clean the bedside table, clean the floor. This is the scheduled or telephone and any other environmental surfaces in the patient room or patient module. The second type is an emergency cleaning. Emergency cleaning for any something in a schedule, you must have as an emergency plan. Emergency cleaning, it is done. I can give example to you. In ICU, we start cleaning every 8 hours. It is a scheduled cleaning. But during these 8 hours, we have an emergency contamination. Some drops of blood during fixation of central line or fixation of peripheral line. Some body fluid drops in the surface, maybe sputum, maybe vomit, maybe what so and so. Yes, what we have to do? We have to wait for the next time of the schedule? No, we have to apply the emergency cleaning and disinfection at once. This is the second type. What is the third type? Is the project cleaning. Project cleaning should be done by the maintenance department, because as you see, all air vents and air condition openings could be transferred to that we can see on the slide. A lot of molds, a lot of the dust, and this is very dangerous for those patients, because in ICU we are dealing with patients with critically ill patients. They are in great risk. Some of them are most of them are immunocompromised, and they can acquire any infection from these contaminated or soiled air vents. This project cleaning, again, done by maintenance department, but should be supervised by infection control or nurse in charge. And this is according to the unit. If it is noticed it needs to be cleaned every month, should be done every month. If every 3 months, every 3 months, no problem. I forget to say something about scheduled cleaning. Scheduled cleaning, it is for all environmental services. We must have scheduled cleaning every 8 hours, and scheduled cleaning for walls, and scheduled cleaning for floors, and for ceilings. Ceilings will be maybe every 3 months, 4 months, 2 months, according to the situation of the unit. But walls maybe every month, according to the situation also of the unit, but this also will be transferred to a terminal cleaning when the patient discharged, and will go to the terminal cleaning. I don't mention in my lecture what is the disinfectants and the detergents used, because many hospitals, every hospital have a list of disinfectants and detergents. There is many. Usually I am not interfering in selection of disinfectants, but I'll give you the key to select proper disinfectant from proper area. Isolation room, you have to select certain disinfectant or level of disinfection. We are talking about levels of disinfection. We have 3 levels of disinfection: low level, intermediate level, high level. This is an example for something I like it very much, and it's too cheap. It is a chlorine-based disinfectants. Chlorine-based disinfectant, it is a household chlorine product, any chlorine product, well-known concentration. It is a known disinfectant and cheap and easy to be purchased and easy to be freshly prepared, and can give us the 3 levels of disinfection. We have, as due to, according to the concentration or dilution. If we prepare 200 parts per million, it will give low level disinfection. If we make it somewhat concentrated, up to 1,000 parts per million, it can give us intermediate level of disinfection. And we can go to a high level of disinfection. High level of disinfection, it is used usually in isolation rooms and also in treatment and cleaning after removal of blood and body spray. I like sodium hypochlorite, chlorine-based disinfectant very much because it is cheap and easy to be available, but should be prepared and diluted freshly every day and be avoided from exposure to light because it will be affected by light, and should be prepared freshly every day because the preparation, if passed, if being after 24 hours, it will lose its activity against microorganisms. We'll go to cleaning of the blood and the body fluid spills. We will talk about what is called spill kit. Spill kit, it is a kit prepared and specialized kit prepared and should be available in our unit, and all nurses and housekeepers should be trained by infection control to how to use this spill kit. Spill kit, again, it is used when there is any blood or body fluid spill from the patient. If there is the blood and the body fluid spill in the environmental surface, we have to bring the spill kit and use it. Shortly, I'll tell you the steps of how to deal with blood and the body fluid spill. If we had body fluid pooling or body fluid spill on the ground, on the environmental surface, on the floor, besides the patient bed, how to deal? You have to put a sign. It is a sign to show the others that there is a biological contamination in that area. And after putting this sign, you have to wear your PPE. You have to wear the mask. You have to wear isolation gown or apron. You have to wear clean gloves, latex gloves, not heavy-duty gloves, and bring the kit. First, we have to transfer the blood or the body fluid from the liquid state to the semi-solid state. How to do that? By spraying some as we see, some of powder. This powder is called super absorbent powder. Super absorbent powder can, after a few minutes, maybe 3 to 5 minutes, can solidify the blood and make the blood in semi-solid state, and easy could be collected by two pieces of carton of plastic and discarded in the yellow bag as infectious material. After that, you have to clean. How to clean? You have to use high-level disinfectants. The best high-level disinfectants and should be used for cleaning the area with after removal of that blood or body fluid from the area. You have to use high-level disinfectants. You have to use chlorine, sodium hypochlorite with the concentration as we said. After that, collect everything and remove your PPE and practice hand hygiene and discard the PPE in the yellow bag, and this is considered as a part of the how to deal with the blood and the body fluid spill. And sure, all nurses and housekeepers in the ICU should be trained very well how to use this kit. Effective cleaning strategies to mandate healthcare environmental safe. We have to improve. If you want to make, you have effective cleaning of the environment, you have to improve the cleaning and disinfection for the rooms after discharge of the patient, because this is very important, because it is considered a terminal cleaning. Daily cleaning for the high-touched surfaces is very important, because daily cleaning or every shift cleaning, it will lower the microbial load on that environmental surfaces. As we said, the doorknob or the monitor buttons should be cleaned every 8 hours or every 12 hours according to the load of work in the unit. All portable equipments, as we said, like oxygen pulse oximeter, any portable equipment should be cleaned regularly, in regular basis, to decrease the microbial load on these environmental surfaces. Okay. First, how to clean the room. We have to ask the person will go to the clean of the patient module or patient room to practice hand hygiene first, and wear gloves and go to the frequently touched surfaces to clean. And starting clean from clean to dirty, from high to low. If there is, we have to avoid to make splashes during cleaning or aerosols, because this can contaminate others outside the room or inside the room. But should be this procedure. If we have to make splashes, we have to wear eye protector, like glasses, goggles or face shields. we have to be sure that the proper concentration of the disinfectants are used. In intensive care unit, we have isolation rooms. When dealing with isolation rooms, we have to know very well that the person will go to clean the isolation room should know the type of isolation and where the personal protective equipment used. The same personal protective equipment should be used with the patient according to type of isolation. It is a contact or droplet or airborne. Also, isolation room should be the last in the schedule. And the equipment used for the cleaning and the disinfection of this room should be dedicated for that room, not used for any other area or any other room. If we have not enough equipment, the equipment should be cleaned thoroughly after being used in the isolation room, and that room should be last in the schedule. These isolation rooms should be minimally cleaned and disinfected using intermediate level disinfectant. This is the personal protective equipment should be worn by the person practicing doing the environmental cleaning. It is going to apron, gown, gloves, heavy-duty gloves, and goggles if there is risk of splashes or aerosolization, and also surgical mask or N95 respirator if that patient isolation room for an airborne transmitted disease patient. This slide is very important for you and for me also. This slide is give us the idea about the level of disinfection and the level of disinfectants versus the resistance of microorganisms. As we know, the bar on the left with blue color, it affecting, this is the low level of disinfectants, low level disinfection affecting all these microorganisms to the down, from enveloped viruses, gram-negative positive bacteria, large non-enveloped viruses, gram-negative bacteria, and fungi, some fungi, and small non-enveloped viruses could be affected by low-grade disinfectants. Low-grade disinfectants, we have many of low-grade disinfectants in our hospitals. But usually in ICU, I like to go to the intermediate level disinfectants because the intermediate level disinfectant can affect mycobacterium. And mycobacterium, it is our limit in intermediate level of disinfection. If we have risk of bacterial spores or fungal spores like Clostridium difficile or Aspergillus spores, we have to go to the high level of disinfection. Usually we are not using high level of disinfection for all times, for all rooms, for all areas or all patients. If we have a patient isolated for Clostridium difficile or another organism need high level disinfection, we have to use. Why? Because high level disinfectants are potent and can affect the environmental surfaces, like monitors and other things. Sometimes high concentration of chlorine or other disinfectants can affect that environmental surfaces. But in intermediate level disinfectants is somewhat gentle, can't affect these surfaces. But this is the minimum level to be used in ICU. All of us, we have to know in ICU, we have to know to clean the environmental surfaces in ICU should be cleaned by intermediate level disinfectants. We have three facts. What is meant by facts? It is a facts not to be discussed, known well. There is no proper disinfection without proper cleaning. Why? As we said, because the soiling or organic soiling can make the environmental surfaces if have soiling not cleaned well, this make barrier between these infections. This affect the property of this infection. And also, if left for a long time, it will dry and couldn't be removed well. This is a fact. There is no proper disinfection without proper cleaning. Second fact, that housekeeping or environmental cleaning and disinfection is in healthcare setting, and ICU is one of these, is a responsibility of all workers, healthcare workers. The third fact, the potential role of environmental reservoirs such as surfaces and the medical equipment in the transmission of MDROs has been a subject of several reports. There is many reports and many outbreaks for multi-drug resistant organisms. The hypothesis give us the reservoir is the environmental surfaces. That's why I told you the environmental contamination is very important in transmission of hospital-acquired infection and causing outbreaks. I'm sorry. Area decontamination technologies like vaporized hydrogen peroxide and UV germicidal irradiation. First, we have to know what is meant by area decontamination. Area decontamination, it is a term called also terminal cleaning. What is the area decontamination and the terminal cleaning? It is the cleaning and disinfection of all environmental surfaces in the patient care area or patient room after discharge or transmission of the patient. After the patient being out of that room and it will not return, we have to make the area decontamination or terminal cleaning. And what is the practices and the activities we have to practice in terminal cleaning and area decontamination? In area decontamination or terminal cleaning, we have to clean and disinfect every centimeter inside the patient room. Even the reusable equipment should be cleaned and disinfected. All surfaces, the wall, the ceiling, the floor, the monitor, the bed, the mattress, the bedside table, any part in the room should be cleaned and disinfected properly. This is what is meant by terminal disinfection. And this is very important for prevention, to give an infection from the previous patient to the new patient, because the previous patient have some pathogens, have some colonizations, some microorganisms. All environmental surfaces inside the room, be sure, trust me please, that all of them are contaminated with the same microorganisms. And these microorganisms will wait, if not cleaned properly and disinfected, will wait for the new patient to infect the new patient and give him infection. What is the methods of for terminal decontamination? We have to use manual methods. Manual method, it is a human, one person can go inside the room and clean every centimeter inside the room and disinfect every centimeter inside the room. But as a human being, it is difficult for us to reach and go for every centimeter without any mistakes. That's why we ask the technology to help us. We need the technology to help us because sometimes we need to use high concentrations of disinfectants to affect maybe multi-drug resistant organisms, bacterial spores, and it will be harmful for the personnel using this disinfectant to disinfect the room of that patient. That's why we go to the technology. What is the first technology? Approved technology could be used. We can use the hydrogen peroxide. Hydrogen peroxide, it is present in two types. Very common type. It's a dry mist hydrogen peroxide in concentration from 2% to 7%, and vapor hydrogen peroxide in concentration from 30 to 35%. Really, both can go as dry mist or vapor for some time inside the room in no presence of any personnel, no human being inside the room, and the room must be sealed because hydrogen peroxide in that concentration, if escaped from the room, can affect the healthcare workers present. It can make irritation of the eye, can make for persons have some respiratory problems and history of bronchial asthma, can irritate the respiratory system. Sorry. This technology is highly effective because it can reach by high concentration to every centimeter inside the room, even bathroom, even all the wall, even the monitors, even the hidden areas behind the drawer or bedside table. Every part can be reached. There is no mistake, but the proper concentration should be used. And the problem of this technology that it is irritant and need aeration for the room and take long time, somewhat maybe 2 hours to aerate the room after finishing the area decontamination by this method. There is another method, sorry. UV germicidal irradiation by ultraviolet. Ultraviolet is a new method used nowadays widely for area decontamination. Also, ultraviolet equipment couldn't be used in presence of a human being. The room should be empty, and because for sure the UV can affect the retina of the eye if of the human being. That's why it should be used in a room free of human beings, and it is more easy, and it is not a chemical at all. It is a light, but have a problem. What is called shadowing problem? Shadowing problem. It is a light, and light go in straight lines. And if the hidden parts couldn't be affected by that light, by that light, and it is not being will not be disinfected by this method. There is many equipment can solve this problem, but this is not our issue now. But we have to know that the use of technology, we can use hydrogen peroxide and ultraviolet irradiation, UVC, for area decontamination after patient being discharged or transferred. We'll go to the last part of our lecture. I'm talking about environmental cleaning, disinfection, quality monitoring. As any practice, as we say, we need to monitor the quality of environmental cleaning. How to know that your environment is safe? If the patient discharged and asked my housekeeper or my nurse charge to clean and disinfect the area surface, environmental surface inside the room, how to know and check that every surface is cleaned properly and decontaminated properly in that room, in the patient room? How to make it? Also, we'll go to manual method or human being method. It's a visual auditing or visualization or observation. I have to sit to observe the person working and cleaning the room to make sure that he is passing over every centimeter inside the room. Direct observation by a supervisor. It is an old method and it could be used, but we can use technology also in the monitoring by using a pseudogerm fluorescence. This pseudogerm fluorescence and UV light, I'll go inside that area needed to be cleaned by the healthcare worker, and I'll make by this marker areas in the commonly touched surfaces I know. Okay, like doorknob, bed rails, monitor, buttons. Also, I can go for this area and make marking. This marking couldn't be visualized except by UV light. I'll go after finishing the process of area decontamination or cleaning, terminal cleaning, and visualize that areas with UV light to see that the fluorescent is present or not. If present, this means that area is not wiped and cleaned and disinfected properly. And this meaning that the process of environmental cleaning is not proper at all. And also there is another type using what is called adenosine triphosphate. Adenosine triphosphate, it measures the residual organic matter left on the surface. It is by equipment. We can take swab and put it inside the equipment to measure the organic matter, residual organic matter. If there is a lot, this means that area is not cleaned and disinfected properly also. But the question, we can use environmental cultures, samples and cultures as a method to be sure of for the process of environmental cleaning in ICU. Could be as a routine. The answer is no. Never to use the environmental samples and the cultures as a method of quality monitoring of environmental cleaning and disinfection, or to be sure that the environment is safe in ICU. Why? Because this is not practical and this is costly, and this will give you also an idea, small idea about the surface you took from that surface, the culture. And what about all the surfaces? This is not a practical method, okay? But when we can use environmental cultures. We can use environmental cultures in 3 situations. Only if there is an outbreak, as we said, and the hypothesis said the environment is a reservoir for infection and have the same microorganism that present in the patients for that outbreak, we can take cultures to prove that hypothesis. And also for research purposes, some people make a research. Research is a rule of environment. As we said, a lot of researchers play about the rule of the contaminated environment in causing hospital-acquired infection. For research purposes, I agree. We can do it. And the third is for after major construction, you can make environmental culture before reopening of the unit to ensure that that unit is safe. Why we should assess the quality of environmental cleaning? Why? Because many reports from all over the world, from best centers, give us the idea that the improper method cannot reach even 48% environmental cleaning, quality of environmental cleaning. Lastly, factors that influencing the effectiveness of cleaning and disinfection process. This process could be affected by the type of the product, and the concentration, and the contact time, and the technique used, if you are using good technique, and the equipment used for cleaning and disinfection. And also physical and chemical factors like pH of the water used for dilution, and also temperature. And I am adding also the cleaning, proper cleaning or not. if you are not clean properly, there is never to have, you will never get a proper disinfection. I think this is the last slide for me. This is also again to remember me and you that we are heroes. Thank you. I think we are before we have 10 minutes. If you want to ask any question regarding the environmental cleaning in intensive care units. Okay, thank you. Thank you. See you, inshallah.
Thank you, Dr. Sameh. Now we go to the last presentation about transmission-based precaution. Dr. Hanan Hathout, I will share my presentation. Assalamu alaikum. I am Dr. Hanan Hathout, MD Community Medicine and Public Health. I work in General Directorate of Infection Prevention and Control, MOH. My topic today is about transmission-based precaution. I know most of you hear about the transmission-based precaution. First, what is the transmission-based precaution? Transmission-based precaution, first, we have two categories of isolation precaution, standard precaution and transmission-based precaution. Anyone in the chat can explain to me difference between standard and transmission-based precaution? What is the difference between standard and transmission-based precaution? Yes. Standard is for all patients, yes. Standard is for all patients, yes. And what about transmission-based precaution? Yes. Standard for all patients, but the transmission-based precaution is for patients with infectious disease. So the difference between standard precaution and transmission-based precaution, standard precaution is applied for all patients at all healthcare settings, whether or not the patient may have infectious disease. But transmission-based precaution, you know that this patient have a certain infectious disease. According to mode of transmission of infectious disease, there will be a certain category of infection control precaution dedicated for this patient. Transmission-based precaution based on route of transmission, designed to be used together with standard precaution, divided into three subgroups of airborne, droplet, and contact precaution. The type of infectious disease a patient has dictate the kind of isolation precaution necessary to prevent spread of disease to others. So we have three categories of transmission-based precaution according to the mode of transmission. This is the standard precaution that should be applied for all patients. This is the transmission-based precaution, which include airborne, contact, and droplet precaution. طيب, what about contact precaution? Which infectious disease the patient have that may require contact precaution? Anyone can answer me, please, in the chat. Give me an example of an infectious disease that require contact precaution. Yes, MRSA, MDRO, VRE, C. diff, yes, very good. Clostridium, yes. Extended spectrum, okay. VRE, okay, very, very good. Okay, so an example, contact precaution is applied for patients who have multi-drug resistant organism that can be transmitted by contact transmission. Contact transmission can be either through direct contact transmission or indirect contact transmission, in which the environment play an important role in transmission. So contact precautions are to be used for disease transmitted by contact, either direct with the patient or patient environment. So patient environment play a very important role in transmission of infectious disease, especially multi-drug resistant organisms that may survive on surface for long duration, as Dr. Samih discussed in his lecture. Disease caused by organisms that have been demonstrated to cause heavy environmental contamination, as you said, VRE, methicillin, MRSA, C. diff, respiratory syncytial virus, and other examples. Like, what are the components of contact precaution? Once you have patient suspected to have an infectious disease transmitted by contact, colonized or infected with multi-drug resistant organism, so you should constitute a contact isolation. Type, what are the components? You should maintain standard precaution at all time plus component of contact precaution. What are the type of room indicated for patient with contact transmission? Single room is preferred. Always single room is preferred. What if single room is not available? So the solution is cohorting, is to place more than one patient, but to have same organism or same disease in the same room, but keeping equipment, keep separation between the patient, and every patient should have a separate zone with patient equipment. In cases where there is shortage of patient room, prioritize patient cohort by condition that may foster transmission. Type, personal protective equipment recommended in case of contact precaution is to wear gown and glove on room entry. This is a standard for all contact isolation, is to wear gown and gloves, but other PPE may be required according to risk assessment. Change gown and gloves between patients, even if both patients share a room and or one or both are on contact precaution. So it is dedicated for one patient care. After finishing care of one patient, you must dispose or doff PPE and do hand hygiene. Type, patient transport. What are the rules for transportation of patient on contact? One basic rule is to limit the patient transport outside the room as much as you can, only limited to absolutely necessary purpose. Inform the receiving department of transmission-based precaution state. So before transport the patient, you should contact the receiving department that my patient are on contact isolation. You should wear glove and gown. You should comply with hand hygiene. You should disinfect the environmental surface after transport the patient. All precaution that should be applied by staff in the receiving department. If there is any body fluid or leaking body fluid or wound, you should cover or contain potentially infectious body fluid before transport. The transporter should discard contaminated PPE before transport. Don't clean PPE to handle the patient at destination. طيب environmental measure very important to clean daily the patient room with a focus on high touch surface, patient bathroom area close to the patient or patient zone. Environmental service worker should don gown and glove before room entry to clean and disinfect the patient room. Some virus and spore forming organisms resistant to traditional disinfectant and use of 1 to 10 dilution of bleach recommended, especially for C. diff. طيب, notify infection control staff that the patient placed on contact isolation. In the room, in the isolation room, whenever possible, also assign non-critical patient care equipment to be used only in isolation room. Avoid sharing of equipment between isolation room and the other room. If there is shared equipment or instrument, you should clean and sterilize before reuse on any other patient. Management of the patient, encourage the patient to observe strict hand hygiene with a personal hygiene. Also explain purpose of precaution to patient and visitor in order to solicit their cooperation. Before visitor is allowed to go inside the isolation room, you should contact the head nurse or infection control nurse to discuss with her what are important precautions that should obey inside the patient isolation room, how to do hand hygiene, how to avoid touching the patient surface and else. This is an example of a poster that should be attached or should be placed on outside of the patient isolation room and should be appropriate with the patient diagnosis. So if the patient on contact isolation, the sign outside should denote that this patient is on contact isolation. This should be available both in English and Arabic. All healthcare workers that allowed to enter inside the room and all visitors must obey with this rule. This include before entry into the room, do hand hygiene, wear gown and gloves, and before exit from the room, you should doff or take off the gown and glove and do hand hygiene. This is the transportation card that should be attached either to the trolley or patient bed during transportation. You should inform the receiving department about the patient diagnosis. You should prepare the patient before transport through covering of any wound, any leaking body fluids, through wearing a clean gown by the patient and cover the patient with a clean sheet. Healthcare worker should wear clean gloves and perform hand hygiene after taking off and disinfection of the wheelchair or patient bed after transportation of the patient. Discontinuation of contact precaution. This is an cooperated decision between infection control and infectious disease consultant. Generally, contact precaution are discontinued when sign and symptom of patient have resolved or according to pathogen specific recommendation. There is a guideline that should be followed when you take a decision for discontinuation of the patient on contact isolation, because some disease require complete cures, some require lab investigation or swab that should be necessary swab to be negative before discontinuation of the isolation. So there is a difference in decision according to the infectious disease, and there is a detailed guideline related to this available in GCC manual, and there is update always of this guideline. This is for contact precaution. What about droplet precaution? Example of droplet precaution. Can you give me example of disease that require droplet precaution? Yes, COVID-19, meningitis, yes, COVID-19 if stable, influenza, yes, meningococcal meningitis, very good. طيب تمام. TB, pulmonary TB, no, pulmonary TB is an airborne. H1N1, okay. يبقى for droplet precaution, what are criteria of infectious disease transmitted by droplet? The droplet particle are characterized by being larger than 5 micron. These particles do not spread in air for long distance, only for about 1.5 meters. It is transmitted when an infectious patient cough or sneeze and transport the infectious particle to the nearby person. Because these particles are large in size and heavy in size, does not transport it to long distance. After some time, it will be settled on surface and cannot be traveled by air to long distance. Type example of infectious disease that are transported by droplet, including influenza, meningococcal meningitis, rubella, and mumps, and transmission via large particle droplet require close contact between source and recipient person. Because droplets don't remain suspended in air, generally travel only short distance, usually 3 feet or less through air. As I said, the droplet does not remain suspended in air. After some time, it will be settled on surface. What are the elements of droplet precaution? Initiate and maintain droplet isolation precaution when there is suspected or confirmed diagnosis of infectious disease transmitted by droplet. What are the type of room? Single room is preferred, but if not available, so we can cohort more than one patient with the same disease, but to keep a distance of about 6 feet between patients with a separate equipment. Personal protective equipment recommended for dealing with patient on droplet precaution is the only surgical mask. Handle item contaminated with respiratory secretion with glove. It's important to change PPE between patient and perform hand hygiene. Patient transport, very important also. Limit patient transport outside the room to medically necessary purpose. If the patient must leave the room, instruct the patient to wear a surgical mask and follow respiratory hygiene cough etiquette to contain any respiratory secretion, to use a paper towel, to dispose of the towel immediately after use. Once the patient is masked, this is a new recommendation from CDC that if your patient can wear a mask and he is able to wear no respiratory distress and able to wear the mask, healthcare workers don't need to wear a surgical mask. Very important to notify a receiving department of the isolation precaution status. Always maintain standard precaution with all patient care. Again, when possible, assign non-critical patient care equipment to use only in isolation room. Avoid sharing of equipment between patient between room. Environmental cleaning with a focus on high-touch surface. After patient discharge or patient transfer, you should do comprehensive terminal cleaning of all surface and change everything inside the room. This is the sign for droplet precaution according to MOH. It is red in color. It should be available on outside of the room of patient on droplet precaution. It is available in red color. It is available in English and Arabic. All healthcare workers should obey with this rule. Single room. Very important is hand hygiene. Wear a surgical mask before going inside the room, and before leaving the room, you should take off the surgical mask and do hand hygiene. This is the transportation card for droplet precaution. You should inform the receiving department of patient diagnosis and isolation type. Prepare the patient for transport. If the patient could wear surgical mask, it's okay. Educate the patient about respiratory hygiene and cough etiquette. Healthcare workers should perform hand hygiene after patient transport. If the patient can tolerate wearing a surgical mask, healthcare workers should wear a surgical mask during transportation. Staff should disinfect a patient bed, wheelchair using MOH approved disinfectant. Discontinuation of droplet precaution, again, this is occur after sign and symptom have resolved or according to pathogen specific guideline. For airborne precaution, example of airborne precaution. Can you share with me? Airborne precaution, example of infectious disease require airborne precaution. Yes, tuberculosis and chickenpox. طيب, what about chickenpox? What are the type of precaution required for chickenpox? All three types, contact and airborne, yes. So for chickenpox, it is transmitted by two types. It is transmitted by contact, through contact with a vesicle, and through air. So there is two types of precaution for chickenpox. It is a contact precaution and it is airborne precaution. This is give us a new idea that you may institute more than one type of precaution. For example, for varicella or chickenpox, on outside room, you will see two posters, one for contact precaution and one for airborne precaution. Type airborne precaution, it is indicated for infectious disease that have a character of being very small, less than 5 micron in diameter. These give a special characters of airborne particles that can be traveled by air for long distance. And these give us need to give extra protection against airborne particle. So there will be a special room for this type of infection, and also there will be a special personal protective equipment dedicated for this type of infection. طيب, what are indication of airborne? يبقى زي ما قلنا used to prevent or reduce transmission of microorganisms that are airborne in small droplet nuclei or dust particle containing the infectious agent. These can remain suspended in air or be dispersed widely by air current, even through ventilation system. They can be inhaled by or deposited on a host in a same room or farther away. Include such disease like pulmonary TB, measles, varicella, or chickenpox. Initiate and maintain airborne isolation precaution when there is suspected or confirmed diagnosis of infectious disease that transmitted by airborne route. Put airborne isolation sign on a door. وهنشوف دلوقتي الساين. Patient placement. What are the type of room recommended for patient with airborne infection? Place the patient in airborne infection isolation room with a negative air pressure relative to corridor. There should be at least 6 to 12 air exchange per hour, and air should be directly exhausted to the outside. Monitor the air pressure daily with a visual indicator. All of this room should be equipped with audio-visual monitor, so that you should ensure that the air inside this room should be under negative pressure, even in the weekend, or if no patient inside the room, no shutdown of the monitor of the room. طيب, notify infection control that the patient is in isolation. Maintain standard precaution with all patient care activity. Non-susceptible healthcare workers should not enter room of patient with varicella or measles if other healthcare workers are available. Type. What about special personal protective equipment recommended for this type of infection? You should wear a fit-tested NIOSH, National Institute of Occupational Safety and Health, NIOSH approved N95 or higher level respirator for respiratory protection when the patient has suspected or confirmed pulmonary TB. So this is a special type of personal protective equipment recommended for dealing with airborne precaution. It should be first fit tested. What about fit test? It is a special test used to select the type of N95 that fit for you and that you should wear with each contact with the patient. Last, fit test, N95 mask is not appropriate for certain category of healthcare worker like beard person. So the alternative is to wear paper or powered air purifying respirator. Environmental measure, routine cleaning of high-touch surface is standard. Environmental surface personnel should wear N95 respirator on the room entry. After the patient has left the room, it is recommended or patient is discharged, the room should remain unoccupied for enough time to allow for complete air exchange to occur. In some facility, recommended time for 1 hour. What about patient transport? Limit the transportation of the patient to essential purpose. If it is necessary, so I will ask the patient to wear a surgical mask and instruct him or her to observe respiratory hygiene and cough etiquette. If the healthcare worker, if I can ensure that the patient can wear the surgical mask without removing it, so healthcare worker don't need to wear N95 during the transportation. Explain the purpose of precaution to the patient and the visitor in order to solicit their cooperation. Check with the visitor and the staff for their immune status to disease and instruct them regarding use of protective apparel and conduct in isolation room. This is the isolation sign. Airborne precaution should be kept on outside of the patient with airborne isolation. So before entry into the room, you should do hand hygienes and wear N95 mask after doing the fit test. And with every use, you should do the seal check to ensure that you wear the N95 properly and there is no leak around the mask. Before leaving the patient room, you should take off or remove all PPE except the N95 mask. That only PPE that should be removed outside the patient area, because as you are in the patient room, you are still at risk. So you should get out of the patient room, close the door, and then take off the N95 mask. For patient transportation, only inform receiving department, ask the patient to wear surgical mask and educate him about respiratory hygiene and cough etiquette and do hand hygiene. If the patient can wear surgical mask, it's okay. No need for healthcare worker to wear N95 and environmental cleaning after transportation of the patient. Discontinuation according to pathogen-specific guideline. This is only example of some infectious disease and how to discontinue isolation precaution recommendation and duration of isolation. For example, if there is the big abscess or big draining abscess, the type of isolation recommended is contact isolation if it is major, and the duration is duration of illness. Yani after the lesion have been dried, so no need, you can discontinue isolation. For HIV, it is a standard precaution. Here for chickenpox, the precaution is double precaution. It includes airborne and contact. Duration of isolation, there is a vesicle in chickenpox, so duration of isolation until all lesions are dry and crusted. For epiglottitis or meningococcal meningitis type of precaution, it is a droplet precaution. Duration of isolation 24 hours after starting of effective antibiotic treatment. I have two case study. I will read it and you can answer question in the chat or a healthcare student is assigned to a client who is on isolation precaution and need assistance with hygiene and elimination. The client is 47-year-old, diagnosed with C. diff and wear an adult diaper due to incontinence of stool. The client has requested assistance with passing and changing their diaper. Okay? First question, but I think the answer is available, but no problem. Okay. طيب, what infection prevention control practice should be incorporated to decrease risk of spreading infection when providing care? What are type of isolation precaution recommended for patient with C. diff, and what are the element of these precaution? Contact, yes. Gloves, gown, yes. Contact, gloves and gown, yes. Hand hygiene, very important is to do hand hygiene. Type, what type of hand hygiene? Only hand washing, because hand rub is not effective in this case. Type, environmental cleaning. Yes, environmental cleaning, stress on environmental cleaning with use of what? Environmental cleaning with use of what? Yes, with chlorine, disinfection with 1 to 10 chlorine disinfect. Very good. Chlorine 1 to 10 to disinfect the spore of C. diff. طيب. يبقى, what infection prevention control practice should be incorporated to decrease risk of spreading infection? Correct hand hygiene, wear glove and gown when changing the client diaper, change the glove between procedure, hand hygiene with antimicrobial soap and waters after removing gloves. طيب. طيب, what infection prevention education should be shared with the patient and their family? طيب, ايه education you can offer education for the patient and his family? Yes, hand hygiene. Yes. Prepare PPE. Yes. Yes, okay. Perform hand hygiene, wear appropriate personal protective equipment, maintain hygiene practice to maintain risk of spread, to decrease the risk of spreading infection to vessel. Case study 2, 10-year-old client has been admitted to clinic with influenza virus and has a fever, persistent productive cough, and runny nose. The client is lethargic and has not ate since yesterday morning due to nausea. Okay. What are the type of isolation precaution recommended for this patient? Droplet precaution, yes, droplet. For influenza, it is droplet. Droplet and standard, yes, we agree that standard is for all patients, but specific isolation precaution for this patient is droplet, yes. And also even in case of droplet precaution, there is discharge and there is large droplet that can be settled on surface after some time. So in some reference for droplet infectious disease, you need to apply post droplet and contact. Yes, very good, Janice. What are the elements of PPE required for dealing with this case? Surgical mask, yes. Surgical mask, even gown and gloves also. Hand hygiene, very important, yes. For close contact gown and glove. N95, why N95? No need for N95. It is a surgical mask because influenza is transmitted by droplet. Okay, any droplet infection, if you are dealing with droplet infection, but you will proceed to do some aerosol generating procedure, you should shift the type of isolation to airborne isolation, only in case of aerosol generating procedure. What are personal protective equipment? Gloves due to body fluid, gown, and the mask should be worn within 2 meters of the patient due to body fluid and productive cough. Teaching strategy for the patient, respiratory hygiene, cough etiquette, and hand hygiene. Okay. Now I finish my topic. I think we finished before the time. Okay. Now we reach the end of the first day. we are sorry for some inconvenience at the beginning of the course, but we try to wait until all participants join the course, so excuse us. I hope that the lecture will add to your knowledge and experience and will be translated